Good afternoon. I'm going to go ahead and call to order the Senate Committee on Health and Human Services for Tuesday, May 4th at 3:35 p.m. with a roll call.
Senator Hardy.
Here.
Senator Harris.
Here.
Senator Kekeffer.
Here.
Senator Spearman.
Here.
Senator Ratty.
Here. All right, welcome everybody to Senate HHS. We have, I think, almost a full capacity here in the hearing room, and I know some folks who are interested on Zoom. For those of you who are working to participate with the Senate Health and Human Services Committee today, I think we're hopefully getting to the place where we're figuring out how this all works. But if you're having any technical difficulties, on the Nevada Legislature website, you can go to the Help tab. It should be on every page, and that will help you know how to register to participate, just in case this is the first time that you are trying to participate in a legislative hearing. Today in Senate HHS, we are going to hear 4 bills. The bill order will be Senate Bill 420, then Assembly Bill 205, Assembly Bill 96, and then Assembly Bill 217, so that you're able to plan your afternoon. For Senate Bill 420, we are anticipating a significant amount of interest. And so as of right now, the plan is to hear the bill, have testimony in support for 30 minutes and testimony in opposition for 30 minutes. I'll just remind everybody that our goal is to build a good record of the information for the bill. And so not everyone may make it through on the phone lines. If that is the case, I would just like to say, if you have written testimony, make sure that you are submitting it to the email address that's on the agenda, and any testimony that is submitted today for any of the bills that we're hearing by midnight tonight, we will make sure it gets included in the record. So that's how we're going to manage the hearing for today. With that, I'm going to go ahead and open up the hearing on Senate Bill 420 and invite Majority Leader Cannizzaro to present the bill.
And thank you so much, Chair Ratty, for having me here today with the Senate Health and Human Services Committee. It's my pleasure to be here for my first time this legislative session. And thank you to the committee members for being here to let me present to you Senate Bill 420 for your consideration. For the record, my name is Nicole Cannizzaro, and I currently serve as a senator from Senate District 6, which is located in the northwest portion of my hometown in the Las Vegas Valley. Today, Madam Chair, with your permission, I do have joining us virtually a few folks who will help aid in the presentation. We have Katie Keith, who is an associate research professor and adjunct professor of law at Georgetown University, Shaniqua Hawkins of Care with Purpose Medical Center in Las Vegas, and Dr. Randy Lampert, also in Las Vegas, who will provide a bit more perspective on this issue. I will be asking each of them to provide testimony in just a few moments. Also here to assist with technical questions as we walk through the bill itself is Stacy Weeks of Aurora Health. So I want to first talk to the committee a little bit about the problem which brings Senate Bill 420 before you all today. One of the most common concerns that I hear walking and talking to Nevadans, whether it's in my district here in Carson City or anywhere in between, relates to the cost of health care, and I can't overstate that enough. Polling and studies also reflect and provide data to support that reality. According to the Kaiser Family Foundation, the cost of health care ranks at the top of things Americans worry about. It affects every aspect of patient experience, and it touches everything from decisions about whether to seek care to the impact of medical bills after receiving care. And importantly, it affects decisions about insurance coverage. And it's not just families who are concerned about the cost of care. In research released just last week, the Kaiser Family Foundation also found that more than 90% of business leaders surveyed believe that there is a greater role for the government to play in controlling healthcare costs and providing coverage options, including potentially public options. In the years following the passage of the Affordable Care Act in 2010, Nevada expanded Medicaid and began offering private health insurance on the Silver State Health Insurance Exchange. The portion of Nevadans without health insurance did decrease significantly. However, in more recent years, the uninsured rate has remained stubbornly consistent and among the highest in the nation at approximately 11%, right here in Nevada. In fact, with nearly 350,000 uninsured Nevadans, our uninsured rate is the 7th highest in the nation. Nevadans pay some of the highest costs, but we still struggle with disappointing health outcomes. And for anyone who has ever had to seek any sort of health-related services, you probably have your own personal story about that same similar situation. Senate Bill 420 seeks to help address this problem by expanding affordable quality health insurance options for all Nevadans. Senate Bill 420 will provide these options to individuals shopping in our state's individual market and also may provide a new, more affordable opportunity to small businesses who have often struggled to find affordable health plans to cover their employees. As members of this committee may remember, in 2017, the legislature passed a Medicaid buy-in legislation. The legislation was vetoed in part because Governor Sandoval felt it moved too quickly and merited further study before implementation. As you will see, we have taken that into consideration, both through the SCR 10 study, which helped shape this legislation, and in the legislation itself, which allows for further analysis and an implementation timeline that deliberately unfolds over several years, giving us plenty of time to be sure we get this right. This bill comes at an even more critical time. We are more than a year into a global pandemic that has resulted in job loss and, consequently, the loss of health insurance. People are struggling to ensure they will have access to health care if they get sick. And that is the plain and simple place that we are in reality. Now is an opportune moment to take advantage of the state's considerable bargaining power to make healthcare more affordable and more accessible by enacting Senate Bill 420. This bill will improve access to healthcare for Nevadans in two key ways. First, by requiring the establishment of a public health insurance plan. And second, by making various changes to Medicaid to expand access to care. Before we walk through the provisions of the bill, Madam Chair, I would like to invite my co-presenters to say a few words, beginning with Katie Keith from Georgetown University, and I believe she should be joining us virtually.
Thank you, Senator Cannizzaro. Ms. Keith.
Thank you so much. Thank you to Senator Cannizzaro. Good afternoon, Chairwoman Ratty and Vice Chair Spearman. It's an honor to be with you. My name is Katie Keith. I'm an associate research professor at Georgetown University, where I study access to health insurance coverage. I also write a blog series for the journal Health Affairs, where I focus entirely on implementation of the Affordable Care Act and any new federal and state healthcare policies.
Ms. Keith, I'm going to interrupt you just for a second. You're a little bit quiet, so I don't know if you can get closer to the microphone, or BPS, if you can help us by bumping her volume up a little bit. Thank you. Go ahead.
Okay, thank you. And hopefully that's a little bit better.
That is, thank you.
Okay, terrific, thanks. I wanted to say I'm especially honored to join you all today because I think of Nevada as my home. So I'm speaking to you from Washington, D.C., but I lived in Las Vegas before I moved to DC. My family has been there for 15 years, and it truly is where I think of as home. My father was in the retired military. He worked at the Nevada test site. My mother was a nurse at a long-term care facility. I worked at United Way of Southern Nevada and at a resort on the Strip, where I was a proud member of the Culinary Workers Union. So it is just an extra delight to be here with you all. I've also had the unfortunate experience of navigating healthcare in Nevada after my father was diagnosed with and ultimately passed away from leukemia in 2012. He was treated at many, many hospitals throughout the valley. I think he was hospitalized 22 times during his course of treatment. I think we have experience with each of those health systems there. And as you can imagine, we had some very positive experiences and some very negative experiences, as Senator Cannizzaro pointed out, and had to ultimately make the very difficult decision to seek out treatment for him in California. So while I'm here testifying as an expert today, just please know the issues that we're discussing are very personal to me and do make an important difference to families like mine. So turning then to today's topic, I really would like to share 4 key data points with you to help inform your consideration of SB 420. These and additional data, and probably more data than you'd ever want, are also included in my written testimony for your review. First is the high uninsured rate in Nevada. Senator Cannizzaro, I think, touched on these points already, but even after embracing the Affordable Care Act, Nevada continues to have stubbornly high uninsured rates, including some of the highest in the country. Before the pandemic, 14% of Nevadans, about 350,000 people, did not have health insurance. And we think that number has gone up simply because of the pandemic and different coverage losses. Indeed, Nevada is one of the only states with expanded Medicaid to continue to have a very high uninsured rate and remain among those top states. Many uninsured people do currently qualify for Medicaid or for subsidized marketplace coverage through Nevada HealthLink, but about half do not. Currently, 44% of the uninsured do not qualify for marketplace subsidies or cannot even enroll in marketplace coverage at all because of their immigration status. Even with the very important federal changes made under the American Rescue Plan, these individuals will continue to be locked out of affordable coverage options unless federal and state policymakers take action. And SB 420 would begin to address some of these gaps. My second data point is on the high healthcare prices in Nevada. Per person healthcare spending in Nevada has grown by 35% from 2013 to 2018 alone. It's lower, that truly is lower than in some states, unfortunately, but Nevadans across the board report a lot of difficulty in affording care, as Senator Cannizzaro mentioned. In 2017, 48% of all Nevadan adults reported that they could not afford the health care that they needed. That put Nevada in the bottom third of states in terms of healthcare affordability, and a separate report ranked Nevada 39th out of 43 states in 2020 for affordability. I would emphasize this is all pre-pandemic data, and so I imagine that these numbers are far worse given the economic instability wrought by the pandemic, with many more people being probably less likely to afford the healthcare that they need. The third data point I'd like to hit on is Nevada's healthcare system itself, which is largely dominated by for-profit insurance companies and hospitals. The state's largest private health insurers are among the nation's most profitable companies on the Fortune 500 and have seen double-digit increases in profits from 2019 to 2020 at least. Nevada is also the first in the nation for-profit hospitals, meaning Nevada has the highest percentage, 54%, of for-profit hospitals more than any state in the country. And many hospitals are owned in full or in part by larger national companies, including one of the 3 largest for-profit hospital companies. In 2019, Nevada's acute care hospitals had a reported combined revenue of $6.8 billion, with net income of just over $511 million. It goes without saying that the pandemic has certainly had an effect and impact on hospital finances, and certainly some healthcare providers are struggling, but this cannot be said for many of the major hospital systems, given rebounded utilization of healthcare services, billions of dollars in aid from the federal government, and continued profitability that we've heard on recent earnings calls. The fourth and final data point that I really want to emphasize, because I think it's core to what you all are discussing today, is that despite all of this healthcare spending, Nevadans still face some of the worst health outcomes in the country. In one ranking of state health system performance by the Commonwealth Fund, Nevada ranked 49th overall in 2020, ahead of only Mississippi and Oklahoma. A separate ranking by United Health Foundation, which is the foundation of the United Health Group, one of the largest insurance companies in Nevada, ranked Nevada as 48th in terms of access to clinical care. As you all know, access and outcomes are often even worse for those living in rural and frontier areas, and we continue to see significant disparities in outcomes based on race and ethnicity as well. As much as Nevadans are paying, healthcare outcomes remain poor, which increases long-term costs and reduces overall productivity. These 4 data points underscore that the status quo is not working for Nevadans. The uninsured rate and healthcare costs remain high, health outcomes remain poor, while for-profit healthcare insurers, hospitals, and prescription drug companies continue to do well. As of now, there are twice as many uninsured people as there are in Nevada's individual health insurance market, showing we could make much more progress in insuring more people. Having more people insured and in high quality plans would help everyone. It would limit medical debt and uncompensated care for healthcare providers and consumers alike, and it would help Nevada policymakers like this committee turn to even more pressing issues, such as true healthcare delivery system reform, increasing access to primary care and behavioral health services, and making sure that Nevada has a high quality health care system and not just a hospital system. I'll end there, but thank you again for the opportunity, and I'm happy to answer any questions.
Thank you, Ms. Keith. My intent committee is to make it through the presentation and then open it up for questions across the board. Go ahead.
Thank you, Madam Chair. Next, we have joining us Shaniqua Hawkins of Care with Purpose Medical Center in Las Vegas.
It does not look like you are, it looks like you are still on mute, Ms. Hawkins, so let's see if we can solve for that.
Okay, can you hear me now?
I
So
can.
sorry.
Please go ahead.
Hello there. Good afternoon, Madam Chair and members of the committee. Thank you for the opportunity to have me today. For the record, my name is Shaniqua Hawkins, Shenakwa, last name Hawkins, and I am speaking for favor of SB 420. Thank you, Majority Leader Carazano, for proposing this legislation, for having me here today and to help describe why it's needed. I am a healthcare provider and a small business owner. I'm an advanced practice registered nurse, and I do run Care with Purpose Medical Center here in North Las Vegas. We predominantly serve communities of color and low-income communities, including a large homeless population. I am in support of this legislation for a number of reasons. Firstly, I personally know what it's like to lose a job with your health insurance. I lost mine at the start of this pandemic when the clinic I worked for shut its doors. Our practice here at Care with Purpose Medical Center sees and treats many people that are in the same situation that I was in. I have been a registered nurse and a nurse actually for over 20 years, including in emergency and trauma centers. And I know that not having health insurance means that people end up needing expensive emergency care because of conditions that we could have, treated proactively if they had been able to afford health insurance. I see this far too much. It is heartbreaking and, a bit frustrating. Anything we can do to make this health insurance more accessible and affordable, this will help, and I believe that this bill will do just that. Secondly, as an APRN, the pay parity provision of the bill will allow me to keep my clinic doors open. There is so much healthcare inequality in our existing system. That's part of what inspired me to open the practice and serve historically underserved populations. We are providing the same level of care with preventive medicine and management of chronic diseases, such as hypertension and diabetes and high cholesterol, especially these problematic, medical conditions in the communities of color. Pay parity will allow me to keep my doors open here at Care with Purpose Medical Center. There are many other reasons why I support this bill, and I can tell you many of stories all day about patients that we see who had, if they had affordable health insurance and been able to go to the doctor or see a provider earlier, these medical crises could have been averted. Cost of insurance is a major factor, and so I will end by reiterating that this bill will help bring costs down, help communities like the ones that I serve here at my clinic, and I ask and urge that this bill be passed to help us. Thank you.
Thank you.
And finally, Madam Chair, we have joining us Dr. Randy Lampert.
Hello, thank you for having me. My name for the record is Dr. Randy Lampert, Randy R-A-N-D-I, Lampert, L-A-M-P-E-R-T. I am a pediatrician practicing in Las Vegas, and I live in State Senate District 6. I'm honored to appear before this committee today and share my perspective as a physician on this important proposal. I support a Nevada public option because I have seen in my career too many people go without health care or ration their medical treatment. I have seen too many parents struggle to pay their medical bills because out-of-pocket costs for their child's treatment were unaffordable. Let me share with you the story of the parent who had to choose between buying food for the week or paying for her child's asthma medication. She delayed buying the medication, hoping that her child would not have an attack until she could save up to purchase the inhaler. She just needed to buy time until the next paycheck. But her child's asthma wouldn't wait, and they ended up in the emergency room. While the child did well with appropriate treatment in the ER, she suffered unnecessary invasive treatments and missed several days of school in order to recover. Worse, their emergency care ended up costing thousands of dollars. That family was devastated emotionally and financially and the child suffered physical and developmental setbacks. I have seen many other families that cannot afford health insurance at all for their children. They earn too much for Medicaid, but premiums on the exchange are too expensive. They come in once a year for a physical and to get their child's vaccines, which thankfully are covered by the Vaccines for Children program. But they can't afford to get recommended labs and medicines or to see specialists that are needed to address more serious health concerns. Imagine being a parent in that situation, trying to make ends meet with an insurance plan that came with huge copays, expensive premiums, and high out-of-pocket costs. Worse, imagine not having insurance at all, with no way to see a doctor or go to a clinic. Imagine being that parent with a sick child and deciding for even a second whether to pay for food or to help make your child's pain go away. Nearly every parent I know would choose their child's well-being, but too many of them do so at the cost of the week's groceries or gas for the car, and no Nevadan should have to make this choice. Getting basic health care and seeing a doctor when the need arises are simply becoming too expensive for too many people in Nevada. A Nevada public option can give people the choice they want and deserve, an affordable, comprehensive coverage that provides health, security, and peace of mind for their families. The Nevada public option expands the menu for families, so it's not just a choice between groceries and health care. There can be both. Low-income families, families of color, families who lose their job and their health insurance, all families will have another choice, a better choice. The status quo isn't working for the families I see every day. The Nevada public option will ensure that every parent can bring their child to a doctor when they need to and never have to pause for even a second to do the math about whether they can afford to. As a medical professional, I urge you to support this legislation. Thank you for your consideration.
Thank you.
And Madam Chair, with your permission, I would like to take this opportunity to walk briefly through the bill. I will note that we did provide a conceptual amendment that provides a few of the items that we needed to clarify in the bill and that we've worked with some stakeholders on. I will advise the committee that there were a few other amendments that had been proposed to us that we are still currently reviewing. I would anticipate that you may hear about some of those as well, but we are taking those into consideration. But members of the committee should have the proposed conceptual amendment that I had submitted. And as I walk through the bill, I'll highlight where those portions of the conceptual amendment are also reflected. So specifically, the public option, the Nevada public option, requires the director of the Department of Health and Human Services, in consultation with the executive director of the Silver State Health Exchange, Commissioner of Insurance in the Department of Business and Industry, to design, establish, and operate a public health benefit plan called the public option. The primary goals of the public option are to leverage the state's purchasing power to reduce health insurance costs for Nevadans, improve access to high-quality, affordable health care for residents, including those who are employed by small businesses, reduce disparities in access to care and health outcomes, and increase access to care for historically marginalized communities, and to increase competition in the individual health insurance market to improve health insurance options for rural Nevadans. Pursuant to Section 10 of the bill, the public option must be made available to all Nevada residents, both as a policy of individual health insurance through the exchange and for direct purchase. It may also be made available to small employers or their employees. Section 10 further requires the public option to meet requirements established by federal and state law for individual health insurance or health insurance for small employers. To keep costs down, premiums for the public option must be at least 5% lower than the premium of the second lowest cost silver level plan available on the exchange in the relevant zip code, and they must not increase by more than the Medicare Economic Index in a given year. Under the conceptual amendment, these requirements may be revised at the direction of DHHS, the executive director of the exchange, and the commissioner of insurance if the public option is on track to reduce average premiums by at least 15% in its first 4 years of operation. I should also note that the conceptual amendment changes the plan year in which the public option would be available from 2025 to 2026 in order to better align with the next round of Medicaid managed care procurement. Section 11 of the bill requires the director, executive director, and commissioner to apply for certain waivers to obtain federal financial support for the public option, and it authorizes them to contract with an independent actuary to assess the impact of the public option on healthcare and health insurance markets in the state. Section 10 requires the director of DHHS to use a statewide competitive bidding process to solicit and enter into contracts with health carriers and others to administer the public option. In order to increase competition, health carriers that provide Medicaid managed care plans in Nevada must participate in the competitive bidding process. The bill also authorizes the director of DHHS to directly administer the public option if necessary. In our conceptual amendment, we have also added bidding preference criteria to reward plans who can demonstrate that their public option product will better align with MCO networks, include value-based care arrangements, and provide for adequate coverage in rural areas and underserved communities. Sections 13, 21, and 29 of the bill require healthcare providers and facilities that participate in Medicaid, the Public Employees Benefits Program, or the state's Workers' Compensation Program to enroll as participating providers in the public option and to accept new patients who are enrolled in the public option to the same extent as they accept new patients not enrolled in this plan. Our amendment will clarify that a provider must only contract with one public option plan and not every plan offered. Section 14 requires aggregate reimbursement rates under the public option to be comparable to or better than Medicare reimbursement rates. It also requires the director of DHHS to establish healthcare provider networks for the public option that minimize disruptions in care for those who lose coverage through Medicaid or the Children's Health Insurance Program and enroll in the public option. The director must also encourage the use of value-based payment models, reward delivery of high-quality services, and lower the cost of care throughout the state. Section 15 establishes the Public Option Trust Fund to hold certain funds for the purpose of implementing the public option. The bill makes various additional changes to ensure the public option is treated similarly to comparable forms of public health insurance. With respect to the bill and beyond the public option, the second part of Senate Bill 420 makes various changes to Medicaid. Importantly, it expands Medicaid coverage for pregnant women with the hope of improving health outcomes and reducing health disparities by expanding access to critical prenatal and postpartum care, among other services. Currently in Nevada, non-Hispanic, Black, American, Indian, Alaska Native, and Asian Pacific Islander populations have the highest rates of severe maternal morbidity, which includes potentially life-threatening conditions and maternal complications. Rates for these populations are approximately double those for non-Hispanic whites. In addition, non-Hispanic Black women have the highest pregnancy-associated and pregnancy-related death ratios, accounting for less than 15% of all deliveries, but 25% of all pregnancy-associated deaths and 33% of all pregnancy-related deaths. As the single largest payer of births in Nevada, Medicaid is uniquely positioned to improve maternal and child health outcomes, and it is my hope that expanding health insurance coverage and access to care for pregnant women will improve existing health disparities and maternal and child health outcomes for moms and babies in Nevada. Section 24 of the bill enhances Medicaid services for pregnant Nevadans to ensure that more expectant parents and their children receive quality prenatal and postpartum care. It requires the director of DHHS to expand coverage for pregnant women under the state plan for Medicaid in 3 ways. First, it increases the income cap on Medicaid eligibility for pregnant women from the current limit of 165% of the federal poverty level to 200%, which is $25,760 for an individual or $53,000 for a family of 4. Second, it requires Medicaid to expedite enrollment for pregnant women through a policy of presumptive eligibility, which allows certain entities to help women enroll in Medicaid without submitting a full application that includes the proof of eligibility. The period of Medicaid enrollment continues until the last day of the month immediately following the month of enrollment, during which a pregnant woman must submit a full Medicaid application for coverage to continue. Third, it prohibits DHHS from requiring a pregnant woman who is otherwise eligible for Medicaid to live in the United States for a certain amount of time before enrolling in Medicaid. Currently, lawfully residing pregnant women must have lived in the United States for 5 years before they are eligible for Nevada Medicaid. Nevada is not alone in considering or implementing these policies. According to the Kaiser Family Foundation, 42 states have higher income limits for pregnant women than Nevada, ranging from 171% of the federal poverty level in Kansas to 380% in Iowa. 30 states expedite Medicaid enrollment for pregnant women through presumptive eligibility, and 25 states allow lawfully residing pregnant immigrant women to enroll if they have not lived in the United States for 5 years, as long as they are otherwise eligible. Section 25 further expands access to care for all Nevadans by requiring Medicaid to cover the services of community health workers who provide services under the supervision of a physician, physician assistant, or advanced practice registered nurse. Section 26 requires Medicaid to cover certain costs for doula services. Section 27 requires a fee-for-service Medicaid to reimburse APRNs to the same extent as services provided by a physician. And Section 28 requires Medicaid to cover breastfeeding supplies, certain prenatal screenings, tests, and lactation consultation and support. Finally, in an effort to improve access to care for Nevada's rural residents, Section 30 requires DHHS to establish a Medicaid managed care program to provide health care services to Medicaid recipients in all geographic regions of the state, rather than just in urban areas, as is the current practice. The department must conduct a statewide procurement process to select health maintenance organizations to provide these services. We are proposing to amend this section to ensure that under statewide managed care, rural providers and FQHCs could expect to receive at least the same rates as they are today under fee-for-service. Finally, this conceptual amendment creates a new section directing the exchange and DHHS to seek a waiver from the federal government to allow multi-employer health trusts to offer their plans on the exchange under certain circumstances. We have a lot of Nevadans who are covered under these plans, and they often work in industries that are particularly sensitive to challenging economic circumstances. This waiver could be an innovative way to make it easier for these plans to continue to provide continuity of coverage to their members, leading to more consistent care and overall better health outcomes. Chair Ratty, we have heard time and time again that Nevadans need more affordable health insurance. We have heard from small business owners, their employees, the uninsured, the underinsured, and those who have lost their jobs in insurance as a result of the pandemic. They need health care. And frankly, they need affordable insurance options. I would be remiss if I also didn't share that I grew up in a very working class family with parents who worked paycheck to paycheck at minimum wage jobs. But one of the things that we always had, because my parents were lucky enough, and especially my dad, was lucky enough to be part of a health insurance program that meant that when we went to the doctor, it was affordable for my parents. When we were sick, we got to go to the doctor, and for the longest period of my life until I became an adult, I thought that the doctor cost $20 because that was what we paid. I didn't know that doctors were more expensive than that, but that's because we had quality, affordable health insurance for a family of 5 that meant that we paid $20 when we got sick, and I got sick quite a bit as a young kid. When I was an adult and had lost my insurance, which I couldn't have even comprehended why that was such a dangerous predicament to be, but I was in my 20s and in college and I didn't have health insurance. And then I injured myself quite badly. And that bill followed me until after I had gone to law school and after I had sought to become an attorney, because I didn't have access to health care. And so many families are not 20-something-year-old college students who went on a payment plan that eventually paid off over many, many years. Currently, and I can speak to some of the reasons why I think the Medicaid pieces of this bill are so important and why overall we should be talking about how to provide affordable health care coverage. I am a consumer of quite a few medical services in preparation for a little one. But those services I am also lucky enough to have insurance coverage for, and they're still expensive. For families who don't have that, I can't imagine what it must be like to wonder if your baby is okay, or to wonder if the person carrying your child is going to be okay. And I believe that doing nothing is not a solution. And so this is the proposal that I think helps get us there. It is both personal to me, and it is something that over the course of the last few years, I cannot reiterate enough I have heard at the doors of so many of my constituents, that affordable health care is something that we have got to tackle. So with that, Madam Chair, I would remain open to any questions that the committee may have. as well. I would note that we do still have, I believe, our presenters if there were questions for them. And I also have Stacy Weeks from Aurora Health to help answer some technical questions if they do come up as well.
Great. Thank you for the presentation. I'll go ahead and open it up to the committee for questions. Senator Kiekefer?
Thank you, Madam Chair. I appreciate it. Nice to see you, Madam Majority Leader. Thank you. I've got a lot of questions, and I'm trying to figure out what order to ask them in, and I'll try not to take too much time, Madam Chair. So can I start with the eligibility for people for the public option? You envision it being open to any human living in Nevada, right? And so I guess that question's sort of the rules of the exchange as they currently exist, and what specifically you're going to ask for as waivers to those rules as a part of the innovation waiver in Section 11.
Thank you for the question, Senator, and always good to see you, although it seems you were relieved of your chair duties earlier today. Madam Chair, through you to Senator Kiekefer, Nicole Cannizzaro, Senate District 6. So I do want to actually make this note because I think it is an important one for individuals who are currently covered under their employer health plans, and especially for large employers for multi-employer health plans. This would not be something that would be available to those individuals, right? We're talking about the individual and small group market, and that's what this product would be designed to capture. And with respect to who we're talking about with the public option. Because I think that there has been some conversation about whether this would pull what is the vast majority in Nevada, something like I think 55% of our insured is through their employer, that this would not, under current law and under the ACA, I believe, and I can let Ms. Weeks provide any additional data on that, but they would not be eligible for this because they fall under those categories. So we're talking about the individual and small group market. And then with respect to I think the second part of your question was the waivers that we would be applying for. We would be working with DHHS in order to figure out what exactly those waivers are. We definitely have looked at the 1332 for some of those funds, and want to make sure that there's enough flexibility built in there that if there are other things that we can be applying for as a state, that we're using that in an innovative capacity in order to get those funds to help buy down the cost of the premiums.
Okay. So thank you for that, Madam Chair. So if so for eligibility purposes, it's individual and small group exclusive. And so I'm trying to figure out who we're targeting, right? Because if we've got whatever, I think the number you used was 65% of the state's population that's either already eligible for Medicaid, which is, it doesn't get cheaper than free, right? Or subsidy eligible under the ACA now. If the and my understanding is that a substantial portion of the rest of that population is undocumented, and they're not eligible for subsidy under the exchange. Who are we capturing who are we bringing into this market? Are we going to disrupt the small group market to so massively that it brings people in? Or I'm trying to figure out, understand who's going to sign up.
And thank you. Through you, Chair, to Senator Kiekefer, Nicole Cannizzaro.
Please go ahead, go direct.
Thank you, Chair. Nicole Cannizzaro, Senate District 6. There's also a chunk of individuals who are uninsured, who don't qualify for subsidies, and where that affordability is a barrier with respect to the exchange. And then I don't know if Ms. Weeks is available and would like to provide any additional, I think, data points on those populations.
Ms. Weeks?
Hi, Madam Chair, committee members. I can provide, my name is Stacy Weeks, for the record. I can provide some information about the uninsured market, if it's helpful for the group. And it's based on data from the Quinn study, which was a couple years ago. And so I just want to note that some of the Medicaid numbers, I think, are a little different. Well, I can mention more about that. And also, I think the Department of Health and Human Services has also used this data and prepared a variety of materials for you on it. So you might have seen it before. So out of the 350,000 people, again, Senator Canizaro said that there are 350,000 individual small group. 37% are eligible for Medicaid but have not yet enrolled. So that's a part of the population. 17% experience affordability challenges today in the exchange. This option would be available to them, and if they're eligible for the exchange, an individual could purchase the product. 27% it's an immigration status is the barrier. And it's not always undocumented. It could be an individual who's eligible for Medicaid and they're barred by the 5-year residency rule. So if you have not lived in the United States for 5 years, you cannot purchase Medicaid. And a lot of immigrants struggle with that barrier because they're often low income when they first move to the United States. So 27% is, who on the outside markets, this product will be offered outside and on the exchange. And to your question, Senator, so this product will be available to that 27%. And on the outside the exchange, 19% would be eligible, we know are eligible for Nevada HealthLink, but are not enrolled. There are a variety of reasons for that, and this product would be eligible, it would be available to them as well. So hopefully that answers your question.
Thank you, it does. I appreciate that. For the 17% who you indicated have affordability challenges, I know there was a significant expansion of tax credit subsidy and support through the American Recovery Plan, including increases beyond 400% of federal poverty level. Does that address some of that 17%?
Madam Chair, committee members, I think that question was for me. I apologize. That subsidy amount is temporary, so I don't think it would be a long-term addressing the issue.
Okay, I appreciate that. Madam Chair, do you want me to keep going or do you want me to stop?
Let me check and we'll definitely come back to you. Let me check to see. We'll go to Senator Hardy.
Thank you, Madam Chair. I'll approach it a little differently. I look at the doula and the midwives and the waivers. Is this going to be revenue neutral by using other practitioners and getting waivers with the federal government helping us out? How does it work?
So what I would say is we'll go ahead and have some general conversation about the cost of it. And then, of course, we'll have a deep dive on costs when it gets to the Finance Committee. So I'm willing to open some conversations on finance at the general level. I believe that we do have a fiscal note posted, just also for the committee's benefit. Go ahead.
Thank you, Chair. And that's an excellent question, Senator Hardy and Nicole Canizaro, Senate District 6. So there's sort of two different pieces. The public option piece, when we're talking about establishing that, is separate from the Medicaid eligibility pieces. Obviously, I think the overall goal of Senate Bill 420 is to help increase access to affordable care. And one of the ways that we've been talking with DHHS and the exchange was with respect to some of these pregnant women in those populations and some of the surrounding prenatal and postpartum care pieces. And so in Senate Bill 420, you see reflected in there the inclusion of eligibility for some of these services. Those would not be, and you can see from the fiscal note, would not be revenue neutral. There is a fiscal note associated with them. There are federal funds that obviously would accompany those, as with many Medicaid and federal matching dollars. But that piece is not, I guess I wouldn't say it's dependent upon the public option, and they sort of are operating in different chunks. So the waivers and the public trust fund that we've talked about with respect to the public option is talking about the health insurance as a whole, but some of the Medicaid pieces would cost the state money, which again, we'll have those conversations and I'm sure the Finance Committee at some point, but would, I think, overall bring in some federal dollars, probably help with savings in terms of more acute care for those patients, but two separate things, if that answers your question.
So am I allowed to ask? So
Please do.
I'm looking at the reality of a insurance company providing coverage and looking at the 5% becoming 15%, not in 5 years, but in 4 years. So how does the insurance company or the hospital or anyone figure out how to, the way I see it, they are required to come up with a process to, and I'll call it bid against themselves, trying to bid down in order to be able to still cover lives. How are we motivating them to cut their costs?
Thank you for the question, Senator. Nicole Cannizzaro, Senate District 6. So I think one of the key pieces of this is for individuals who would currently be folks who are looking at the public option, right? They're uninsured, so they're uncompensated care at this point. So when hospitals and providers see those individuals, they're providing that care, and they're uninsured. And so those costs are obviously built in and distributed amongst other folks who are paying for health insurance. The public option is a premium-based plan, so folks would pay premiums for their health insurance, albeit our goal with this is to create something that is more affordable so that people can actually afford it, because I think one of the things that you will commonly hear, and what we see in some of the data as well, is that people may be eligible to get health care, but if they can't afford it, then that eligibility is meaningless. And so when folks are covered, even though it may be a lower cost plan, that is something that is far more than what hospitals and providers would be getting for folks who are on uncompensated care. I think the motivation here, right, is to get more people insured and more people on insurance so that you're not facing that prospect of them coming in and being completely uninsured.
Thank you, Madam Chair.
Senator Harris, anything?
Thank you for the opportunity, Madam Chair. I'd just like to make a quick comment. I think it's a great bill, and I'm happy to see it here in Nevada. Pretty excited. Thank you, Majority Leader.
Okay. Senator Spearman, any questions? Oh, that's right. So Senator Spearman has stepped out because she's presenting a bill in another committee. So I'll take a turn and then we'll come back to you, Senator Kieckhofer. So I think the question that I have is really more about access to insurance does not actually always equal access to care. Depending on how skinny that network might be and their provider list and whether that provider list has waiting lists, or depending on the number of providers that are available, or depending on if we have the specialists that we need in the network. And so how does the bill approach that question of sort of network adequacy and making sure that just because you have insurance also means that you have care?
Thank you, Chair, for the question. Nicole Cannizzaro, Senate District 6. And I think that's a really important piece. And I think one of the key aspects of this bill, or why it is that we should be looking at more affordable options and why we should be motivated to look to reduce costs overall, right, is the same sort of thing. If someone is eligible for insurance and they can't afford it, that is akin to being ineligible for insurance. Similarly, if you are on a plan that either doesn't provide the services that are sort of those basic level services that you may need, or you don't have access to get in to see a provider, then that's akin to having no care at all. And so how do you help solve for that? And Senate Bill 420 has a couple of things in it that I think address that very notion, some of which are that we are requiring for individuals, for groups that are bidding on those MCO contracts to also bid on the public option, to make a good faith bid for that product. That if you take Medicaid patients, that you are also accepting the public option. Similar for workers' comp and PEB, so that we are creating a network of providers statewide that will see these patients and that will accept that insurance, to hopefully address that adequacy of care issue, because I do think that that is an important one. And I think because also we're talking about this being a statewide product, that you're also seeing continuity of care, even if somebody were to, let's say, move, or if they were an individual and simply weren't qualifying or didn't have employer-based health care, that they could also have that flexibility to stay with their providers and make sure that they can continue having that access with this particular product. And I don't know if there's anything that I missed that Ms. Weeks would want to highlight, but I think those would be sort of the key pieces that I would point out with respect to creating that adequate network. God bless you.
Weeks? Okay, nothing to add? Okay.
No, thank you.
Kind of along the same line, so not only are, if I understand the bill correctly, not only are the insurance companies required to bid if they want to bid on Medicaid, but is it also the case that if providers accept Medicare or Medicaid, then they also have to accept the public option? Is that the way it's set up?
Thank you, Madam Chair. Nicole Canizaro, Senate District 6. That is correct. It also includes workers' compensation if they take the state workers' compensation or PED.
Okay.
They would accept the public option as well.
So we've had some challenges with providers choosing to opt out of our Medicaid and Medicare systems because of the rates. And so I guess my question is, do we have any experience with a similar model in other states? Are we concerned about the potentially unintended consequence of losing providers who just choose to get out of the whole public space?
So that is an excellent point. I think I would venture to guess you may hear some of those points as the bill testimony goes on. So a couple of things that I would note about that. First of all, what we're trying to do with this bill, right, is to ensure that there are providers who are going to accept the public option, so people can actually get access to services. Again, I would note that the populations that are sought to be served with this are individuals who currently either are not insured because they don't qualify or not insured because they're having affordability issues, either through their small group employers who are not providing them insurance or through or because they simply can't afford what is currently being offered. And so when we talk about individuals who might say, look, Medicaid rates are really hard, these are not Medicaid rates that are being provided here, right? We're not increasing eligibility for Medicaid and saying, okay, now cover them at your Medicaid rates. We're saying people are going to get on an insurance product, pay premiums for that. And the goal is that there would be some negotiated prices there that would incentivize providers to want to take these individuals, especially when the opposite side of that coin is they are uninsured and we are providing and paying for throughout the system uncompensated care and, frankly, more acute care. As far as other states go, we have not seen other states who have implemented this type of model, but I think one of the important key aspects about this particular bill is that there is built-in time to allow for DHHS to help implement the public option in consultation with the exchange and the insurance commissioner to make sure that we're getting those price points right, that we're making the right decisions in how this would be implemented. And additionally, that we're going to take the time to actually look at the data and make sure that what we're doing doesn't inadvertently price out other, wouldn't necessarily result in a loss of providers and things like that. But the goal was to ensure that there was individuals who would be accepting the public option to create that network of providers. And then I don't know if Ms. Weeks had anything else to add to those.
Thank you, Senator. Madam Chair, committee members, the only thing I might add is that, there is a state that Minnesota actually has a similar provision and for Medicaid, for its Medicaid program and its public employee program and workers' comp. They call it Rule 101 in Minnesota, and it works really well there. Providers, there's very robust networks in Minnesota because of, I think, in part because of that rule. One other thing to note about this is because you're tying it to Medicaid in many ways and doing the procurements together, you're going to be incentivizing plans because they're going to need, if they want to be able to offer the product and obtain the money that Medicaid can bring, as well as this market to, we know the contracts in managed care are close to $2 billion. If they want that, hopefully this would incentivize them to they're going to have to do better by providers to make sure they're in their networks to be able to offer a bid. So hopefully incentivizes plans to come forward and work with providers in a way that maybe they aren't today. That would be the hope.
Great, thank you. And then I would just ask one more question, then I'll turn it back to Senator Kieckhofer for a few more. Can you just walk me through the timeline of it? Because this is, just want to make sure that it's clear on the public record. This isn't effective July 1 turned on and folks have access to insurance in the next year. So would you just walk us through that?
Yes, thank you, Madam Chair. Nicole Canizaro, Senate District 6, and that's correct. And you can see in the in the proposed conceptual amendment on page 2 on item number 9, we did revise this so that it would be available for the coverage year beginning January 1st of 2026 to allow for alignment of procurement. So this is not something that would be implemented July 1st of 2021. Our goal here is to build in that lead time so that there's enough space for DHHS in consultation to provide for that procurement. And then also for us to get the data in the interim through any uses of actuarials that may be necessary in order to make sure that we're putting it in a good spot. And I think that by building in that time and allowing for this to become a plan year that's effective on 2026, that really is allowing the flexibility that's needed. And also the encouraging, hopefully, some creativity on our part as a state to come up with the way in which to implement this that actually does result in savings to Nevadans.
Thank you. Senator Kieckhofer?
Thank you, Madam Chair. I think maybe more just of a comment to start on the issue of maintaining adequate network, right? The bill on its face sort of recognizes that this could be a problem due to the fact that we're going to allow PEB and Medicaid to opt out of that requirement. So we're saying in Section 5, subsection 2, that if we're going to disrupt access for our people, the people we care of, the people that we're directly responsible for through Medicaid and state public employees, that if they're going to have insufficient or difficult access to covered services, that we're going to allow them to waive this requirement for commensurate access. So I think the bill recognizes that this is likely to be a problem.
Did you quote the section again, Senator?
I'm sorry, I misquoted the section. It's Section 13, subsection 2 on page 7 of the bill.
Thank you.
But as to a question, back in Section 10, we talk about the public option, but am I reading it right that there need to be at least 2 plans, at least one silver and at least one gold plan offered?
Thank you for the question, Senator. Nicole Canizaro, Senate District 2. Yes, there would be a gold and a silver plan.
Okay. And then when it comes to the cost, right? And so when you get into subsection 5 of section 10, and as it's amended in your conceptual amendment, how should I interpret subsection 5? Is it that over 4 years the costs of these plans will be 15% less, or should I read it as I originally interpreted it, which is that the average cost of all health insurance plans in the state will be 15% less? Because that's how I think it reads.
Thank you for the question, Senator. Nicole Canizaro, Senate District 6. This is applicable to the public option, not to plans across the state.
Okay, so the targeted price reduction of health insurance is not it's not a downward pressure on all plans across the state to try to reduce premiums. It is specific to solely these 2 public options.
Nicole Canizaro, Senate District 6. Senator, yes, that's correct.
Okay. In the amendment that you offered on bullet point 6 as it related to, I think it specifically relates to the culinary health plan. I don't know how many other plans in the state might currently fit into this definition. Is the idea that they would be A, subsidy eligible if they're offered on the exchange, and B, would they be able to enroll people who are not currently members of their group? So if an association health plan or something like that would fit this category, could they enroll people who are not part of their association?
Thank you for the question, Senator. Nicole Canizaro, Senate District 6. So this, I would say, it's not specific to any particular group. We have a lot of multi-employer plans here in the state, and frankly, a lot of individuals who may from time to time find themselves in a situation where they have lost their health care coverage because of loss of employment for a period of time. And so the goal here is that with approval from federal government for different waivers and subsidies that they might apply for, that this just is essentially going to allow a structure in collaboration with DHHS to make sure that if they wanted to be able to continue to provide that for those individuals who would otherwise have fallen off of their plans, that they could. And the goal there is to create continuity of care and make sure that people can keep their health insurance, even though they may have periods where they wouldn't otherwise remain. And so, part of this is allowing that flexibility and working with DHHS to create what those options are, and then having approval with respect to waivers through the federal government.
So it's not open to the general public, so to speak. It would only be people as a part of the qualified group?
I believe that our intention is to make sure that it is like folks who would still be qualified under that qualified group. But again, I think if there was some indication that it would be feasible to include some individuals like family members that potentially would have fallen off or wouldn't be covered, that they could potentially be covered. But it's not as prescriptive as that in the language and how we're envisioning it.
Okay, I appreciate that. I wanted to explore that.
Senator Kiefer, I'm just going to interrupt you for a second.
Yep.
So we have the intent of the bill on the record, but I would like to kick it over to Eric Robbins to just talk about the 15%, because I think Senator Kiefer, how you read the bill may be how it's reading. So I just let's get that on the record so that if there's the need for amendments in the future, we've got it documented.
Eric Robbins from LCB Legal. The bill requires or provides that the director may revise the performance targets provided that the public option remains on target to reduce average premiums for health insurance in the state by at least 15% over 4 years in the conceptual amendment in which the public option is in operation. And so the text of the bill as I read it now would go along with Senator Kiefer's initial impression, and it would be that it would have to create downward pressure on all of the health insurance in the state and lower the average premiums of all health insurance by at least 15%. So if it is going to carry out the intent expressed on the record today, the bill would need to be amended to reflect that intent.
Thank you for the clarification, Mr. Robbins. Senator Kiefer.
Thank you. I appreciate that, Madam Chair and Council. So just because we say that a health insurance plan needs to have premiums that are 15% less, that doesn't reduce costs by 15%, right? It may actually increase costs and increase utilization, and there are a lot of different factors that could happen downstream. Who's going to pick up that cost?
Thank you for the question. Nicole Canizaro, Senate District 6. So again, I think the important point here is that we are talking about getting at folks who currently cannot afford or are ineligible for the health insurance that currently exists. Yes, there are costs associated with that, but currently those costs are for uninsured, uncompensated for care. It's hard for me because we've had a lot of these conversations, and again, I pose a question that it is more expensive to cover individuals who come in for more acute conditions through the utilization of emergency services more often than not, or where a condition has gone untreated for a significant period of time, and therefore the treatment and mitigation of whatever that disease is far more expensive and far more intrusive and difficult to deal with, and is not currently being compensated for, right? We're not talking about instances where if you, like I do, have health insurance and that's what you're utilizing. We're talking about individuals who otherwise have a much higher cost, getting them insured so they have access to regular health care, which overall will reduce, I think, their utilization of those emergency acute services, and also is compensation where there was none. And so, yes, there are costs associated with that, and yes, we are trying to make it more affordable, but the other alternative is these individuals go without health insurance.
I appreciate the response, and I think that sort of philosophically, yeah, I just don't know if that's where we're going to be getting people from. If we're opening it up to the small group market, that I worry that it's going to poach more people out of that than some of the categories that we're talking about. Like, I mean, if I forgot, I jotted down the numbers, 37% are currently Medicaid eligible, right? If they go into a hospital with a significant problem, those hospitals do everything they can to make sure that they're eligible or enrolled, right? This, same thing for if 5% greater, if we make a plan 5% more affordable than the second lowest silver plan, but people have made the choice not to enroll even though they're eligible on the exchange now. I guess I'm just not convinced that that's going to trigger them to suddenly run and sign up. So I wonder, I worry about where the cost shifts are going to happen to make up for some of this sort of artificial pressure. And I think it's into large group insurance and employer-based insurance and downward pressure on providers.
Thank you, Senator Kieckhofer. All right, Senator Hardy, and then after a couple questions from Senator Hardy, I think what I'd like to do is take us to the testimony. We can still have some more questions after the testimony, but I suspect the testimony may raise some other issues for the committee. So go ahead,
Thank you,
Senator.
Madam Chair. So my practical experiences when the Affordable Care Act came into being, for instance, seeing patients in the office, we would see patients who had saved up all of their illnesses, literally. And so instead of one problem or two problems you were dealing with 5 different diseases all at once. So this kind of thing, I look for that same kind of thing to happen. So there would be an initial, quite an expensive problem that you would be facing. But at the same time, that's the individual practitioner as opposed to the hospital, as it were. And in talking with hospitals for years and years and years, they don't make money on Medicaid. They don't make money many times on Medicare. And so they make up the difference on private insurance. And as I see this going in the downward push to be able to afford everybody, I'm just trying to see how that would balance out, because the more you see, it's the old watermelon truck. If it costs 75 cents to sell a watermelon, you can sell it for 50 cents. You just need a bigger truck kind of philosophy. So I have that problem with, what is it going to amount for the practitioners in hospitals or the hospitals themselves or the insurance companies that have done many things in an investment in the community. And I think that's one of the challenges that we're going to see is the investment in the community while they're trying to push down to that 5% and eventually 15%. More a statement than a question. Thanks, Madam Chair.
I didn't really hear a question in there.
Do you
there?
see, I can make it a question.
No, we don't need to. If I just want to make sure if there was a question, we know what it was. All right, we'll move on to public testimony. So we're going to go ahead and open up public testimony for SB 420. Again, we are going to start with the folks in the room. The entire time for the public testimony in support will be 30 minutes. The entire time for the public testimony in opposition will be 30 minutes. And we are going to limit public testimony to 2 minutes. So I do ask folks to be concise and to the point. If it turns out we have some extra time, we can go back to questions and answers. So we'll go ahead and start with support, and Ms. Complasi is going to help me with the timer. Welcome, please begin.
Good afternoon, Madam Chair and members of the committee. For the record, my name is Annette Magnus, and I'm the Executive Director of Battleborn Progress. We are here today in strong support of SB 420, and we thank the Senate Majority Leader Cannizzaro for her leadership in bringing real solutions to our state's healthcare crisis. Health disparities continue to run deep in our healthcare system. Right now, low-income communities, communities of color, or rural communities face fewer options and higher prices. These health disparities significantly affect women in Nevada. In our state, 1 out of every 7 women of childbearing age is uninsured. You will hear that there are little to no support for a public option in Nevada. That's a flat-out lie, accompanied by inaccurate polling by the opponents, as usual, as scare tactics that we have seen time and time again. In reality, Nevadans are desperate for accessible and affordable healthcare coverage. How do we know this? Because for years, our organizations, along with our partner organizations supporting this bill, have been present in our communities, and we have always heard over and over that healthcare and insurance coverage is something that people desperately are begging for. And they need help from our elected officials too. Plus, we have seen these exact same tactics used in other states when bills just like this were presented. A recent poll by Global Strategy Group found that 66% of Nevadans support a public health care option. It seems like the industry simply doesn't want to provide options and compete for business as per usual. And I'm tired of the excuses at the expense of Nevadans' lives. I want to add that technically I am a small business owner. We pay 100% of our 10 employees' health insurance and their children's. We pay over $5,000 a month in insurance. That does not always cover everything we need, with the best plan available by Sierra Health and Life. I cannot wait for this plan to be available to us so we can have better and more affordable options for coverage. This plan is another piece of the puzzle in solving the insurance and healthcare crisis that Battleborn Progress has been working on for years. We thank the Senate Majority Leader for her work. This bill is a matter of life and death for so many Nevadans, and we are counting on you today. Thank you, and we urge your support.
Thank you. Next in support, and we do have hand sanitizer and wipes if you want to sanitize as part of the process.
Thank you, Madam Chair. My name is David Goldwater. I'm a lobbyist in this building, and I'm representing myself today and the small business I work for. I've worked around health policy since the time I entered politics last year, or almost 30 years ago now. And I have a disclaimer for you, and that is I believe strongly that access to affordable health care is a right of all Nevadans. I'm lucky today to be here as a business owner. I'm a partner in a small retail business that employs about 35 people. I also have a small consulting firm that employs about 3 people. We pay for health insurance for our employees. I feel like if the building were open, the line for small business owners would be out the door in support of this bill, because healthcare insurance costs are such a big part of our budget. It's probably 10 to 15% of our costs, and it represents between 20 and 30% of total compensation to our employees. So why am I here? Because of money. We have an employer-based insurance program, and I guess that's great. That's how we deliver health insurance, is through our employer. Wasn't my choice or anybody else's choice, but that's the one we have. That's fine. Another disclaimer, I believe providers should be paid and paid for their services. And those costs should be fair and not shifted between the insured and uninsured. And the incentives for care should be aligned. The employer-based system, however, is particularly hard on small businesses. That's where the gaps are, and that's where this bill fills those gaps. Small businesses don't have easy access to capital markets, so they're generally undercapitalized. Additionally, most small businesses is the primary source of income. It's a very direct, the dollar that we pay for health care and health insurance for our employees it's felt by the owners. Those monies would otherwise go to our families and provide for our own well-being.
Mr. Goldwater, we're at the 2 minutes, so if you wrap your thought up.
I'll wrap it on up. And we have a very close relationship with our employees. I believe that this bill fills the gap for small businesses in an employer-based system, and I encourage your support.
Thank you. Next supporter?
Good afternoon, Chair Ratty, members of the committee. My name is Priscilla Maloney, and I represent the retiree chapter of ASME Local 4041. I don't usually read my public statements, but I timed this. So our membership is open to both state and non-state local government public employee retirees. We urge your support for SB 420 for multiple reasons, a lot of which you've already heard. We thank the sponsors and co-sponsors of this bill for bringing it forward this session. We believe that a public option in Nevada will serve a critical function in our state, especially now, as our health care and health insurance system has been stress tested by the enormity of the global pandemic this last year, and which has also revealed critical vulnerabilities. Approximately over 350,000 Nevadans are currently uninsured, while the retirees I represent have access to health care insurance through the public employees benefit programs. There are times, depending on one's life situation, where the gap between what is available from programs like the Silver State ACA exchange and income-based programs such as Medicaid is too large for some to navigate successfully financially. In particular, this gap affects the pre-Medicare age population. That population, when suffering job losses later in their careers and the subsequent loss of their employer-provided health insurance, are left only with COBRA as a temporary option. COBRA does not offer affordable short or long-term solutions for those individuals as they age into Medicare. Medicaid has its own limitations and restrictions. Introducing a competitive array of options in the insurance market could be an invaluable tool in bringing Nevada to a place where most, if not all, Nevadans are insured and have access to affordable health care no matter what their life situation may be. We strongly urge your support for SB 420, and if I could just real briefly address the issue of cost shifting. The Kaiser Foundation has multiple, and I would certainly supply the committee if requested, absolutely, the research on this. They have multiple figures and data they've collected over the years of the cost of uninsured. That cost is of uninsured folks accessing care in emergency situations usually is already a cost shifting. It's happening right now. The Public Employee Benefits Program has an excess reserve of somewhere between $20 and $30 million, we believe, right now, because of a situation where we had claim suppression this last year, at least in part. So there is cost shifting already going on in this landscape. And we, again, just urge your support for this very great bill, and we so much thank Senator Cannizzaro for bringing it forward. Thank you.
Thank you, Ms. Maloney.
Good afternoon, Senator Ratty and members of the Senate Health and Human Services Committee. My name is Sarah Adler with Silver State Government Relations, today representing the Nevada Advanced Practice Nurses Association, or NAPNA. NAPNA is the largest association of APRNs in Nevada, who are often referred to as nurse practitioners. As you are aware, APRNs are critically important primary care and specialty care providers. They have full practice authority and are fully accountable for the decisions and the delivery of care that they provide. You'll find more about NAPNA and our support for SB 420 posted to the exhibits. NAPNA supports a public option. They are all about healthcare access. APRNs daily are interacting with Nevadans whom they wish had received access to care sooner in their lives or in the experience of the illness or disease that the APRNs encounter that day. NAPNA also strongly supports and appreciates the inclusion of Section 27 that provides reimbursement parity for APRNs in fee-for-service Medicaid. This is absolutely appropriate. And by providing parity, Nevada will attract and retain APRNs to serving Medicaid patients, the Nevadans who need care perhaps the most. APRNs are difference makers, as we saw from the dynamic young woman advanced practice nurse at the beginning of the bill presentation. Just a moment to you, the policy committee, the good news on the fiscal note. The fiscal note provided by GHCFP, or whatever that acronym is, indicates that the general fund impact of pay parity would be just 7.8 million this biennium. And given the good news from the Economic Forum today, that's just 1.6% of the above December number that was received from the Economic Forum today. So this parity is highly affordable. And finally, I wish to draw your
Ms.
attention to
Adler,
a
that is
proposed
time, so go ahead and wrap it
a
up.
proposed amendment to Section 30. Section 30 is about the statewide MCO. We would propose that pay parity follow the movement to a statewide MCO. Thank you very much, and appreciate your support of 420.
Thank you. Still in testimony on support.
Thank you, Madam Chair and members of the committee. My name is Eric Jang, ERICJENG, representing One APIA Nevada, grassroots advocates for our Asian Pacific Islander communities here in Nevada. Want to thank Leader Canzaro for proposing the public option proposal. As part of our grassroots organizing, we've knocked more than 30,000 doors, talked to more than 2,500 Asian Pacific Islander families in the state of Nevada. Healthcare is the #1 issue for our community, regardless of income, language, ethnicity, or when they moved here, when they immigrated. People are concerned about healthcare. They want to ensure coverage, even if someone loses their job, especially after our community is being hit one of the hardest during COVID. On the small business end, we have also recruited more than 30 prominent Asian and Pacific Islander small business owners to sign on for our support letter, which we'll submit for the committee. On the community member end, our partner group, Asian Community Development Council, provides in-language health navigator to assist our community members to enroll on the exchange, and we saw a huge surge during the pandemic. Lastly, as an advocate for the Asian Pacific Islander communities, we urge your support for SB 420 as it fills the existing gap on the employee-based model and make healthcare in Nevada more affordable, accessible, and equitable. Thank you.
Thank you. All right, we're going to go to the phones now. So BPS, if you could help us for anybody who would like to testify in support of SB 420 with a 2-minute limit.
Certainly, Chair. Thank you. If you would like to testify in support of Senate Bill 420, please press *9 now to take your place in the queue. Caller with the last 3 digits, 130. Please slowly state and spell your name for the record. You have 2 minutes and may begin.
Good afternoon, Chair and members of the committee. For the record, my name is Christine Saunders. That's CHRISTINESAUNDERS. And I'm the Policy Director with the Progressive Leadership Alliance in Nevada in support of Senate Bill 420 today. I submitted written testimony for the record, but I actually want to share a brief personal story with you. Next Wednesday is actually my 5th wedding anniversary, which I will note I recently learned is a wood anniversary. Well, I had been with my partner for many years prior to getting married. The date of our wedding was rushed. It was quickly scheduled at the courthouse to coincide right after my 26th birthday, the day I was no longer covered by my mother's health plan. A policy like a Nevada public option would have made a huge difference when I was struggling to ensure I was still going to be able to have access to my medical care for my chronic illnesses and to the prescriptions I take every day. And in fact, it probably would have been more affordable coverage for both my husband and I rather than utilizing his high deductible insurance plan. On behalf of Plan and myself, I urge that you support this legislation. Thank you.
Thank you. Next caller.
Caller with the last 3 digits, 035. Please slowly state and spell your name for the record. You have 2 minutes and may begin.
Good afternoon, Chair Ratty and honorable members of the committee. For the record, my name is Quentin Savoy, Quentin, Savoy, SAVWOIR. I'm the Deputy Director at Make It Work Nevada. We organize Black women and Black families to build power towards economic, racial, and reproductive justice, and we support SB 420. By now, you all know very well how COVID-19 has ravaged our state and exposed the seemingly countless vulnerabilities that we face as Nevadans. What you may not know are the stories of our community members that have lingering effects of COVID-19. The ongoing loss of taste and smell, the ongoing body aches and mental fogginess, the chronic exhaustion. And of all these people, they have nowhere to turn because they lack insurance or their current plan is far too expensive to afford. But even before COVID-19, we were facing a healthcare crisis in our state. When we surveyed Black women, we learned that more than 20% of them put off visits to the doctor because either one, they can't afford to take the time off from work to go to the doctor, or two, they can't afford the copay or deductible that's associated with their current insurance plan. We heard stories from women in our community like Dee, who experienced chronic pain for decades, regarding it as the growing pains of becoming a woman, is what she described, because she couldn't afford to go to the doctor. This pain only got worse and more severe as the years passed. By the time Dee had both an affordable insurance plan and a job that provided her paid sick time, she learned that she could no longer have children because of her diagnosis. SB 420 will help mitigate one of these two barriers. As we rebuild our lives in this COVID-19 environment, it's fiercely important that our fellow Nevadans have access to health care. Considering this, it is absolutely imperative that all of our families have access to quality, affordable health care insurance plans, especially Black and Brown families, as they have borne the brunt of hospitalizations and deaths during the COVID-19 pandemic. No one should have to go bankrupt when they get sick, and no one should have to choose between going to work or taking care of their family. We urge bipartisan support and deeply appreciate your time. Thank you.
Thank you. Next caller, please.
Thank you, Chair. Caller with the last three digits, 528. Please slowly state and spell your name for the record. You have 2 minutes and may begin.
Good afternoon, Madam Chair, members of the committee. For the record, my name is Barry Gold, B-A-R-R-Y-G-O-L-D, and I'm the Director of Government Relations for AARP Nevada. My full testimony is on NELA, so I'll just briefly highlight it. AARP Nevada believes that people of all ages should have equitable access to quality, affordable health care. We've already heard about the significant disparities in our current health care system, both in terms of access and outcomes. We do support healthcare reforms that significantly improve access to affordable and quality coverage. Many people have the health insurance costs impact how many people approach their life decisions. Many people have kept a job just specifically to retain their health insurance, and many others have delayed retirement just to keep their health care. People often may understand the need for having health insurance, but for many, the cost can put it way out of their reach. Everyone deserves access to quality, affordable health care, and SB 420 contains proposals that move Nevada closer to this vision. AARP Nevada, on behalf of our 345,000 members across the state, support SB 420 and urge this committee to pass it to help more Nevadans and their families have the ability to obtain affordable and quality health care. Thank you.
Thank you. Next caller.
Caller with the last three digits, 362. Please slowly state and spell your name for the record. You have 2 minutes and may begin.
Thank you, Madam Chair. My name is Katie Robbins, K-A-T-I-E-R-O-B-B-I-N-S, and I am here on behalf of Planned Parenthood Votes Nevada. We are proud to support SB 420 and thank Senator Cannizzaro for bringing this important bill. Nevada has one of the highest uninsured populations in the nation, and the Nevada public option will provide higher quality, lower cost care to people across the state. The public option will also help address the disparities people of color and low-income Nevadans face when trying to find affordable, quality care for themselves and their families. Increasing access to health care, including reproductive health care, will make our state stronger and more equitable. Thank you for your time, and we urge the committee's support of SB 420.
Thank you. Next caller.
Thank you, Chair. Caller with the last three digits, 018. Please slowly state and spell your name for the record. You have 2 minutes and may begin.
Good evening, committee. My name is Jim Sullivan, J-I-M-S-U-L-L-I-V-A-N, and I'm representing the Culinary Union. The Culinary Union supports Senate Bill 420 with the Conceptual Amendment because we believe that healthcare is a human right. This bill is a good first step towards making sure that all Nevadans get quality and affordable healthcare. We know that Nevada has one of the highest uninsured rates in the country, which this bill addresses by creating a public option for working families who are either not eligible for a healthcare plan or simply can't afford it. In addition, the conceptual amendment for this bill would allow the Culinary Health Fund to participate in the program, which allows the fund to continue to take care of participants if they were to lose health care benefits. This is important because it would allow Culinary Union members and their dependents to continue to see their same doctors, not face a gap in much-needed treatments, and have access to the same prescriptions and specialists instead of having to start over with a brand new insurer if they were to lose coverage. We thank the Majority Leader for working with us, and we look forward to continue working with all stakeholders to create a public option that works for all Nevadans. The Culinary Union urges the Nevada Legislature to support and pass SB 420. Thank you.
Thank you. Next caller.
Caller with the last 3 digits, 196. Please slowly state and spell your name for the record. You have 2 minutes and may begin.
Good afternoon, Madam Chair and committee members. Thank you for the opportunity to testify in support of SB 420. For the record, my name is Evan Louie, Evan Louie, and I'm a small business owner and executive and board advisor to several Asian American Pacific Islander-owned companies. Just returned from API Lobby Day from Carson City, and thankful to our elected officials for meeting with leaders in our community in honor of Asian Pacific American Heritage Month. I also serve as the executive advisor to Don't Tell Mama LLC, doing business as Kamu Ultra Karaoke. It is a $12 million project in the Grand Canal Shops and the largest karaoke establishment in the United States. We currently employ 25 people in Nevada. Thank you to Senator Majority Leader Canizaro for presenting SB 420, a sorely needed bill for Nevada. Kamu Ultra Karaoke and X-Pot are neighbors in the Grand Canal Shops. X-Pot is a $7 million high-end hot pot restaurant. Due to delays in constructions, both opened in July 2020 during the pandemic. They both incurred severe revenue loss in the name of millions, but providing affordable health insurance is important to their businesses. Both have struggled financially just to retain their employees, seeing little to no foot traffic in their establishments since the early phases of the pandemic. It only makes sense to have insurance providers compete with public option, which will in turn provide lower premiums and expanded coverage. I also read a recent study by Commonwealth Fund listed Nevada as the 48th in the nation for overall health care and the highest uninsured rate of the Medicaid expansion states. As a personal story, my late wife was diagnosed with brain cancer 4 months after we were married and 7.5 months pregnant with my daughter, Savon. I had to stop running my business and live in hospitals taking care of my wife and newborn premature daughter. We barely could survive just keeping up with the COBRA premiums and healthcare costs with severe income loss and our cost of living. After my wife's passing, affordable health care is something I have become extremely passionate about. As a small business owner, I know that competition drives innovation, but having more options is better for everyone. I urge you to support SB 420. Thank you.
Thank you, and thank you for sharing your story. I'm so sorry to hear about your loss.
Thank you.
We are currently on support of Senate Bill 420. If you've recently joined the call, please press *9 to take your place in the queue. Caller with the last 3 digits, 341. Please slowly state and spell your name for the record. You have 2 minutes and may begin.
Good evening. For the record, my name is Daniel Corona, DanielCorona, and I'm calling in support of SB 420 tonight. In the summer of 2017, it was announced that Nevada's 14 most rural counties would have no insurance option through the Nevada Health Exchange. Thousands of Nevadans, including myself, who received health insurance on the exchange would simply be out of luck. Thankfully, state leaders were able to avert a disaster and secure health insurance for rural Nevadans at the last minute. The threat of no available health insurance through the exchange still looms yearly for rural Nevadans. However, thanks to Majority Leader Canizaro, there is potential for an actual long-term solution through SB 420, which if passed will be one of the most comprehensive and robust public health insurance plans in the country. For the first time ever, Nevadans in the most rural areas of our state would be guaranteed access to affordable coverage through a statewide public option. This means rural providers and hospitals will also be guaranteed reimbursement for patients enrolled in the Nevada public option, which would be a game changer, as our rural hospitals provided nearly $30 million in uncompensated care in 2020 alone. Meeting those costs has been crushing Nevada's rural hospitals and is a major factor in why so many have recently closed their doors. SB 420 would also provide rural Nevadans a statewide network of doctors they could receive in-network care from, even if those providers are outside the patient's home county. This, along with the fact that the Nevada public option will be offered to individuals, families, and small businesses, is why, as someone who receives health insurance through the exchange, and as the mayor of West Wendover, a rural community that struggles yearly with access to affordable health care, I stand in strong support of SB 420 and urge this committee to do the same. Thank you.
Thank you. Next caller.
Caller with the last three digits, 248. Please slowly state and spell your name for the record. You have 2 minutes, and you may begin.
This is Dr. Philip Malinas, PhilipMalinas. I'm a psychiatrist in Reno. As a medical professional, I support SB 420. I urge our state's policymakers to expand healthcare access by passing the Nevada Public Option, which can reduce costs and make comprehensive healthcare affordable for all Nevadans. Expanding healthcare is especially essential to the health and well-being of low-income and rural residents. As a physician, I see close up the hurdles my patients face to getting health care. Cost is a major hurdle. Comprehensive care is another. And so is getting specialized care to specific populations and underserved communities. I witness too many Nevadans struggle to get the care they need to stay healthy, work, and care for their families. They have few options. Low-income and rural families often can't afford co-pays and out-of-pocket costs that seem to go up every year, even as these families get fewer services. The public option can address these challenges. A robust and effective public option can protect my patients and your constituents by reining in costs, including by requiring premiums to be less expensive year over year. This will help more Nevadans to keep their health insurance if their income rises and their subsidy under the ACA is reduced. It will also expand critical services such as maternal and pregnancy care access. A public option can improve the health and save the lives of all Nevadans, regardless of where they live. A public option can reduce the burden on small businesses who want to help pay for health insurance for their employees but can't afford to. A Nevada public option can provide families with the protection and the peace of mind they deserve. Thank you.
Thank you. All right, we have time for 2 more to testify in support. If you are still on the line to testify in support, we're going to take 2 more. If you don't make it through, you can send your written testimony to senhhs@sen.state.nv.us, which is the email address that is on the agenda. And you can also submit your opinion on a bill or resolution using the opinions application. There's a web link on the agenda as well. So we'll take 2 more in support, and then we'll move on to opposition. BPS, next caller.
Thank you, Chair. Thank you, Chair. Caller with the last three digits, 957. Please slowly state and spell your name for the record. You have 2 minutes and may begin.
Good evening. My name is Teresa Bohannon, Teresa Bohannan. I am a resident of the Reno area, and I am a mother to a child with a severe congenital heart defect. I'm calling today in support of SB 420. I've long been an advocate for a public option and to fix the problems that the ACA was unable to address initially. And not having a public option was one of the main barriers to accessing affordable health care for everyone nationwide. And we see it specifically here in Nevada, as many people have already stated, the high number of uninsured patients in our state. I believe a public option would help address some of the costs. I also would strongly advocate that while drafting a bill, we also deeply look at max out-of-pocket rates and deductibles. The cost-sharing burden for patients has become increasingly unattainable. In fact, while I was on the call waiting, I was coordinating care for my son in Las Vegas and wondering how I was going to pay for airfare, hotel, travel. So there's additional costs outside of just the cost of healthcare that all patients are struggling to maintain. And I also want to just say that during the pandemic and when it was unsure of how safe schools were, I looked at an option of leaving my job, and I looked on the exchange, and the out-of-pocket rates were incredibly high, about $13,000 out of pocket. And as I stated, as a parent with a child with special needs, I've met those max out-of-pockets as my son's care has totaled over $2 million, and he's 5 years old. So I know quite well the struggles that patients go through every day. And so again, I thank everybody on the committee. I thank the senator for drafting SB 420, and I hope that we can do the right thing and create more affordable and accessible healthcare to all Nevadans. Thank you so much.
Thank you. And last caller in support.
Thank you, Chair. Caller with the last three digits, 922. Please slowly state and spell your name for the record. You have 2 minutes and may begin.
Good afternoon. My name is Ender, E-N-D-E-R, Austin, A-U-S-T-I-N, the third. Good afternoon, Chairwoman Ratty, my soror, Chair, Vice Chair Spearman, and members of this committee. As I previously stated, my name is Ender Austin III, and I'm the Southern Nevada Regional Director for Faith in Action Nevada, a nonprofit that seeks to organize people of faith to, as our name says, put our faith into action. And I come this afternoon to speak on behalf of many of our leaders across the state who've expressed reasons why they support SB 420. SB 420 allows for increased access, mobility, and to foster equity in healthcare. Access to healthcare is a moral imperative, period. I can share a couple of our leaders' testimonies or stories in the short time that we have today. Alita Flewellen shared that access to healthcare allowed her mother, who was dying, to be able to live a dignified life in her final days of life. This was so important that her mother maintained a sense of normalcy even as her illnesses were progressing. Deacon David Ross spoke to me about the importance of healthcare when he faced a heart procedure that cost $250,000. If he didn't have health insurance, he would have absolutely been put in debt that he would not have been able to take care of. Pastor Joe Harris spoke vigorously about the importance of healthcare for Black men who face unique health disparities are exacerbated, by a lack of access to healthcare. Because yes, in 2021, if America catches a cold, Black America has the flu. Furthermore, Pastor Danisha Mingo, who is a mental health professional, spoke about the importance of her patients being able to keep their health insurance when they transition from job to job. So in short, this SB 420, allows folks to carry their health insurance from one job to another, seeks to alleviate some of the challenges that we have with racial disparities, and ensures that there's a better quality of life for many others, as well as providing financial security. And so we ask that you all would please support this life-changing measure. And in a world where so much is going on, I want to remind you that Black Lives Matter. Thank you.
Thank you. Okay, we're going to go ahead and close support and testimony and open up testimony in opposition to Senate Bill 420. So if you guys want to make your way up, you can fill both seats if you would like. Mr. Clark, please go ahead.
Thank you, Madam Chair, members of the committee. I have to say that was glorious. Reaching forward and tapping the button and speaking before you was fantastic. My name is Tom Clark. I'm here on behalf of the Nevada Association of Health Plans. I come before you in opposition to Senate Bill 420, and my opposition is primarily to the sections that deal with the public option. I represent the private insurance companies that operate in Nevada, and so we want to talk about the impact that this legislation will have specifically on Nevadans. The most important concern that we have is cost. Cost on implementation, cost on creating, cost on managing this new public option. The second biggest issue that we have is access to care, and I think some of my other colleagues will discuss those parts of it. I didn't want to get a lot into the amount of time to deliberate and things like that. These are different times. But I can tell you that when there are very challenging things that occur within healthcare, when you lock us all in a room, we tend to find solutions. Surprise billing from last session was a very good example of that. So the healthcare system in Nevada is a system. And when you look at insurance, it's broken down into a number of different ways. You have large group, small group, and individual market. You have the self-funded plans. You have Medicare, and of course you have Medicaid. And as been testified previously, about 11% of those folks are the uninsured. Now, the reason I bring up those other types of insurance is because the system operates as a system. with this concept, with the public option, if you set the rate and you compress a portion of the market, the remaining areas in the system expand to cover and subsidize the costs of the compression. So there was discussion about cost shift. We contemplate that under this legislation, there will be a cost shift where you may see under the public option a set price, but those folks that are in those other elements of insurance will see an increase in the cost of theirs. There was mention earlier about the Monat study. I won't go into a lot of detail on that. Simply that, they brought forward two options. We were hoping to deliberate and discuss those options. One of those options, of course, is outlined in this particular piece of legislation. There was a lot of talk already about ARPA and what the Biden administration has put forward, what Congress has passed. Those policies have opened up the door for the exchange. There's 100,000 folks that are Medicaid eligible that could enroll. There's about 80,000 folks that qualify for basically zero cost insurance through the exchange. We need to work to get those folks into that system. What does 420 not contemplate? The increasing price of pharmaceutical drugs. Network adequacy, something that's very close to my heart, because we have been working as insurers for years to increase the number of providers that we have, rural, urban, across the board as far as discipline, to bring them in. We fear the impact that this particular piece of legislation will have on network adequacy will be detrimental. To just kind of...
Mr. Clerk, I'm afraid that's getting to your 2 minutes, so if you could wrap up your thought.
Thank you, Madam Chair. Under this proposal, the healthcare delivery system access will be impacted, and experience tells us, even the Monat study told us, a public option of this nature will be expensive, and healthcare costs for all Nevadans will increase, access will decline. And with that, thank you, Madam Chair.
Thank you, Mr. Clark. Mr. Wadhams?
Thank you, Madam Chair, members of the committee. For the record, my name is Jim Wadhams. I'm here today representing the Nevada Hospital Association and appreciate the privilege of being here in person. I'll try to be brief. We totally support the notion of a public option. However, we have issues with this bill, and we'll try to be brief, but put those on the record. The one element that's missing in the bill is a prerequisite for an actuarial study. This population needs to be analyzed, needs to be studied, so that the morbidity, if you will, that is the healthcare characteristics, can be understood. That shouldn't be too terribly difficult if a portion of this population is already Medicaid eligible and is available of just simply getting them enrolled. That will cut this approximately by a third to a half, depending on how you calculate that. But there needs to be an actuarial study so that both the insurers know what they're insuring and the providers know what they're delivering service to. One of the issues, and it's been mentioned by a prior witness, that their cost sharing shouldn't be an issue because it's already part of the system. And indeed it is. As many of you who also serve on the money committees know, our Medicaid reimbursements are substantially below cost. And unfortunately, the Medicare reimbursements are below cost. And so using a Medicare or a Medicaid system as a basis mandates that the cost system will be less than the cost to prepare and deliver those healthcare services. That creates a problem. When costs exceed the revenues, then adjustments will have to be made. It's either passed on, typically passed on to the commercial market, that is the employers that are not eligible to participate will have to begin picking that up, or unfortunately it can impact into the workforce and jobs, which is the largest cost factor. The labor factor in facilities will have to be addressed. We tend to think that it will erode the small group and the individual plans, particularly those that are being put together by the chambers that have been so successful. The ultimate problem, I think, is that as we find insurance for more people, we've got to be careful that we don't decrease the access. The concern is that by mandating that certain providers participate, we may frankly lose those certain providers from those other elements of care. For example, delivering care to Public Employees Benefit Plan, injured workers, and state Medicaid. for us in the hospital world, nurses and doctors are the lifeblood that flows through these facilities, and the adequacy of our workforce is critical to the delivery of that care, which was stressed so much in the last 15 months. And without those people willing to put themselves on the line, in the front line, and the facilities adjusting to access capacity, that would have been a problem. My last comment is just please, as you review this bill, remember that that cost comes in different components. It's the cost, the out-of-pocket to the consumer, it's the cost of insurance, and ultimately it's the cost to deliver this healthcare service by the providers. So we got to make sure that we're sensitive to where all of those costs go. Appreciate the opportunity to address this bill, certainly willing to continue to work on a very important issue, and appreciate Senator Cannizzaro bringing the bill, but we do have those concerns. Thank you, Madam Chair.
Thank you, Mr. Wadhams. Mr. Hildebrand.
Good afternoon, Chair Ratty and members of the committee. My name is Jaron Hildebrand, and I am the Executive Director of the Nevada State Medical Association. I'm here to, our membership consists of the majority of Nevada physicians, but we've considered first and foremost ourselves as a patient advocacy organization. We do share the priority of improving healthcare, improving access to and affordability of healthcare insurance. Covering the uninsured and improving healthcare outcomes and affordability has a long-standing priority with the Nevada State Medical Association. Again, I want to stress that we are not opposed to a public option. However, today we are in opposition to SB 420 as written. I sent most of my comments in a letter, so I won't go through the whole thing. But just to touch on quickly the payment parity piece, we do have concerns with some of the payment parity with respect to doulas, midwives, and nurse practitioners. And I know this isn't an apples to apples organization comparison, but I do believe there's a few lawyers in the room here, and I don't know how they would feel if a paralegal was getting the same pay as a physician would or as a lawyer would, for that example. I will quickly touch on two of our major issues with this bill. The mandate in Section 23. We support physicians' freedoms of choice when it comes to healthcare plan participation, and therefore we oppose the effort to require physicians' participation in a public option by tying it to the participation of other state-based programs. This mandatory participation provision overlooks the complexities of running a physician practice, the balance of involved in determining the capacity and the ability of a practice to serve a patient mix. There are many reasons as to why a practice may not participate with the plan: burdensome administrative policies, saturation of practice resources, physician time, engagement in alternative payment models, pending retirement, and so on. It is critical that the physicians are able to weigh in on the contract options and make the decisions what's best for them and the practice and their patients and their staff. Secondly, I would like to discuss the Medicare reimbursement rates in Section 14 of this bill. That would establish provider payments using Medicare rates as a floor. While we appreciate the Medicare rates being meant to serve as a starting point and not the targets for negotiations between providers and plans, rightfully we fear these rates will become a de facto rate for all public option contracts. Simply, Medicare rates have not covered cost of providing care in the commercial market. In fact, according to data from the Medicare trustees and Medicare physicians' pay has barely increased in nearly 2 decades. It has just increased in just 7% from 2001 to 2020, or just 1.3% per year on an average rate. At the same time, costs of running a medical practice have increased over 37% between 2001 and 2020.
And Mr. Hildebrand, you're at the 2 minutes, if you want to wrap up your thought.
Okay. Given the financial risks of setting up a public option at Medicare baseline rates for physicians, and NSMA urges the Nevada Legislature to consider the impact and policy of the long-term sustainability of physician practices and ultimately the access to care to Nevadans, such as we respectfully ask the Legislature refrain from using rates at the floor of physicians' payments under this public option. Despite our concerns above mentioned provisions, there is some sections in this bill that we do support. Again, it's in my letter. I don't have time now with the 2 minutes, but please reference my letter. Thank you very much for being here.
Thank you, Mr. Hildebrand, and thank you for the written comments. Mr. Hillerby.
Thank you, Madam Chair. Michael Hillerby. I represent Renown Health and our insurance division, Hometown Health. We are a local nonprofit integrated healthcare system. While we support the concept of a public option focused on providing coverage for the uninsured, we do oppose SB 420. But we want to work with you and others to see if we can design a program that works for Nevada without jeopardizing access to care or the current options for coverage. As an integrated healthcare delivery system with a health plan, we are acutely aware of the importance of the payer mix as we strive to manage costs and make the most efficient use of public and private dollars. We know that when the number of patients increase in Medicaid, Medicare, and other programs that reimburse below cost, or for those who are uninsured, the cost burden shifts to providers and private health insurance patients. That impacts the number of providers willing to enroll in these programs and see new patients. We are all aware Nevada ranks very low in physicians, nurses, and other primary care providers per capita, and we have among the lowest Medicaid reimbursement rates for hospitals in America. Our delivery system is fragile and sensitive to even small changes in the payer mix, and the same is true for the private insurance market for businesses and individuals. We cannot implement a new public option before we've studied and addressed the risks of losing providers in our current system or making Nevada a less attractive place to practice medicine. SB 420 seeks to address in part the large population of patients who are eligible but not enrolled in Medicaid or subsidized exchange plans. 37% are eligible for Medicaid, as you've already heard, and 20% or more for subsidized coverage on the exchange. We should focus on these areas before implementing a new public option in the waning weeks of the session. We would like to work with you and the larger healthcare community to continue the work done on, for example, the SCR-10 study, the Patient Protection Commission, and the committee to study the cost of prescription drugs. If we are to build a public option that addresses the unique Nevada marketplace, we believe work first needs to be done in the following areas. Increase presumptive eligibility options to better capture more Medicaid-eligible patients and help them complete full enrollment. Explore expanded exchange enrollment opportunities, for example, at point of care. Could we create something like Medicaid presumptive eligibility for the exchange? The actuarial study allowed in the bill must be mandatory if we are to understand the risk pool and the viability of any public option to avoid the results seen in the state of Washington. This was also reflected in the early years of our own exchange and the lack of coverage in rural counties. Also, remove the small employer eligibility provisions. This will exacerbate the cost-shifting problem and create more uncertainty in a small, fragile private insurance market. We must also address Medicaid rates, including the cuts made last summer. We need to align Medicare reimbursement with value-based care and patient outcomes, helping drive better access to the best care in the appropriate setting. We believe this is a crucial step to deal with both access and the very real budget realities that you face every day. We share your commitment to helping more patients access care with viable coverage, and we look forward to working with the legislature to address the current needs and the best plan for the future in a way that encourages providers and payers to stay in Nevada. Thank you very much.
Thank you, Mr. Hillerby. Ms. Fisher.
Thank you, Madam Chair. Committee, for the record, Susan Fisher with McDonald Carano speaking today on behalf of the Nevada State Society of Anesthesiologists. It was mentioned earlier in the comments that 35% of eligible Nevadans, people who are eligible for Medicaid, are not enrolled in Medicaid. Why is that? We need to figure out why. We keep cutting up the piece, looking to cut up the piece of the pie, and nobody is eating that pie, and that's what we need to figure out. We have a lot of the reason why people are not signing up for it is because doctors are not accepting any more Medicaid patients, doctors who can choose. But unfortunately, we have doctors who cannot choose, and so they do take Medicaid patients, and they're losing money in their practices. We have nationwide, we had over 10% of anesthesiologists leave the medical industry. Because of COVID stress, they either took early retirements, we had a lot of deaths and sicknesses, and we're losing providers. Our anesthesiologists here in Nevada, our big provider groups, work very hard to try to recruit more anesthesiologists into the state. We're not afraid of competition. We cannot get more anesthesiologists to come here because of the low, very, very low Medicaid rates. We have submitted a letter that has a lot of comments in there and some more detail. I won't read all of the letter, but we are opposed to this bill. It's well-meaning, but we need to figure out why people are not using the programs that we have now first and fix those. Thank you.
Thank you. All right, we'll go to the phones now. BPS will take callers in opposition to AB 420 with the 2-minute limit.
Certainly. Thank you, Chair. If you would like to testify in opposition to Senate Bill 420, please press star 9 now to take your place in the queue. Caller with the last 3 digits, 456, please slowly state and spell your name for the record. You have 2 minutes and may begin. Caller, if you're having trouble unmuting, you can press star 6 to unmute yourself. There you go. Go ahead.
Good afternoon, Chair Ratty and members of the Senate Committee. My name is Ann Silver, ANNSILVER, and I serve as CEO of the Reno Sparks Chamber of Commerce and a co-director of the Silver State Chambers of Commerce, which include 12 other Nevada chambers. I'm before you today in opposition to Senate Bill 420. SB 420 would increase costs to our chamber businesses and their employees, reduce competition and choice for working Nevada families, and might possibly deter physicians from establishing their much-needed practices in our state. We do support decreasing insurance costs and increasing availability, so we're proud of the Reno Sparks Chambers Association Health Plan, able to offer affordable, comprehensive vision, dental, medical, and life insurance plans to any small business with between 2 and 50 employees. This plan currently covers thousands of lives across the state. SB 420 would not reduce the high cost of health care in Nevada. It would, however, demand insurance premium reductions for a finite number of Nevadans and increase the cost to a larger proportion of the population. Your help is needed in creating incentives for medical residencies, encouraging and funding healthcare credentialing, and refraining from establishing arbitrary government-set reimbursement rates. Your priorities should include encouraging doctors to work in our state and rewarding students who choose careers in healthcare. We respectfully ask that you rethink this bill and instead establish a task force to explore healthcare affordability and existing products in the Nevada market. We currently have enough choices without adding a distraction that may ultimately diminish the healthcare industry, leaving it without a chance to compete and succeed. Thank you for your attention in this matter. We look forward to being included in any further discussions on SB 420.
Thank you. Next caller.
Caller with the last 3 digits, 114, please slowly state and spell your name for the record. You have 2 minutes and may begin.
Greetings, Chair Ratty and members of the committee. For the record, Scott Muellrath, SCOTTMUELRATH, President and CEO for the Henderson Chamber of Commerce, representing 1,800 plus businesses employing more than 150,000 Nevadans. As the Chief Administrator of our own nonprofit association health plans, operating in partnership with the Latin, Urban, and Boulder City Chambers, the Henderson Chamber of Commerce strongly urge your opposition to SB 420. Our current ACA compliant and fully insured AHPs collectively insure over 360 small businesses and over 8,000 lives in Southern Nevada across 12 plan options. It is a proven market-driven solution based on low premium costs and comprehensive benefits, bulk buying power for small business. We are extremely troubled by both the impact this proposal will have on Nevada's families currently receiving employer-provided health benefits and the adverse impacts to access and care Nevadans need from their healthcare network, in effect pushing doctors, our healthcare heroes, out of the Nevada market. SB 420 would create a new government-controlled program that will ultimately provide fewer options and benefits while eroding existing private insurance plans. It will predictably shift remaining healthcare costs not covered by the state to the Nevada families who choose to receive employer coverage, increasing healthcare costs for many. Hospitals and doctors will be paid Medicare rates, which are below the cost of providing services. Again, hospital and doctors will be paid rates lower and below the cost of providing services. Additionally, SB 420 was assembled with no input from those health care providers and administrators in the marketplace that are meeting consumer needs at cost-effective premiums. There is not a one-size-fits-all solution to health care, and SB 420 is not the answer. This proposal puts cost and access to care in jeopardy for thousands of Nevadans. We urge your opposition on this critically important issue. Thank you.
Thank you. Next caller.
Caller with the last 3 digits, 131. Please slowly state and spell your name for the record. You have 2 minutes and may begin.
Chair Ratty, members of Senate Health, my name is Connor Kane, CONNORCAIN, and I'm testifying today on behalf of HCA, Sunrise, Southern Hills, and Mountain View Hospitals in opposition to Senate Bill 420. In the last year, our hospitals have cared for nearly 10,000 COVID-positive patients and ensured that Nevadans, including those in vulnerable zip codes, had access to free life-saving monoclonal antibody treatment, all while sustaining difficult Medicaid cuts brought on by the pandemic's crushing impact to our state budget. We thank Majority Leader Cannizzaro for briefing us on this bill and appreciate her Medicaid enhancement ideas, particularly for pregnant women. However, we still oppose Senate Bill 420 as written. We worry that the current public option proposal will not work for Nevada's unique healthcare environment and will have negative consequences for both patients and providers. At Sunrise Hospital, which is the largest provider of Medicaid services in our state, 16% of our patients are covered through commercial or managed care insurance. Any shift in patients from commercial plans to a public option that would almost certainly reimburse at a far lower rate threatens the ability of hospitals like Sunrise to offer services the most vulnerable members of our community rely upon so heavily. We believe there are other ways to expand health insurance coverage in Nevada. First, over 50% of uninsured Nevadans are eligible for Medicaid or subsidies on the exchange but not enrolled. We should increase efforts to ensure that these folks are enrolled. Second, Nevada has the highest share of those ineligible for coverage due to immigration status. If we truly want to expand insurance coverage, we as a state should ensure that all of those who would otherwise qualify for coverage are eligible for Medicaid. President Biden is currently proposing a permanent extension of expanded premium subsidies available for private insurance through the public marketplace. The idea is to build on the Affordable Care Act. We encourage you to support President Biden's approach to make healthcare more affordable. Additionally, we hope that this body will consider expanding coverage through enhanced enrollment efforts and coverage to otherwise ineligible Nevadans. We again want to thank the Majority Leader and also Chair Ratty for allowing us to provide our input, and we look forward to further discussions on SB 420. Thank you.
Thank you. Next caller.
Caller with the last three digits 020. Please slowly state and spell your name for the record. You have 2 minutes and may begin.
Good afternoon, Chair Reddy and members of the committee. For the record, my name is Mary Beth Sewald, spelled S-E-W-A-L-D, and I'm the president and CEO of the Vegas Chamber. The Vegas Chamber absolutely shares the goal that every Nevadan should have access to affordable health coverage. That's why we and other chambers and trade associations, as you've heard, successfully cover thousands of lives and keep insurance more affordable through association healthcare plans for our small business members. Based on our review of SB 420, feedback from our small and large members, and what has happened in other states, the Vegas Chamber is opposed to the bill. This bill will not reduce healthcare costs. Rather, it will shift costs onto other Nevadans. Also, mandating a state insurance plan to offer a rate 5% lower than commercial rates is another cost shift. Evidence from other states that have implemented similar programs confirms that insurance costs went up, which is very concerning. So what will it do in Nevada? This question should be answered before this bill is passed. Let's conduct a thorough actuarial study and find out. There are also concerns about requiring healthcare providers to accept government-set reimbursement rates. These are currently below the actual cost of providing care. In our opinion, this is not tenable. It will reduce providers who accept Medicaid. It will push doctors out and make it more difficult to find a physician. So what will ensure more Nevadans? Let's expand on what we already have. Enroll more people into Medicaid, the state exchange, and association healthcare plans. Of the current pool of uninsured Nevadans, as we've heard, at least 30% are Medicaid eligible. Enrolling them in Medicaid now would automatically reduce the uninsured population by more than 100,000 lives. Raising reimbursement rates and addressing shortages of healthcare providers are also solutions that will help cover more Nevadans. I appreciate your time, and I urge you not to pass SB 420. Thank you very much.
Thank you. Okay, we have time for 2 more callers in opposition. So again, as a reminder, if you're on the line and hoping to testify in opposition, we're going to take 2 more callers, but there's the email address on the agenda, and if you send written testimony before midnight tonight, we will record it as an exhibit for this hearing. So again, 2 more callers. Next caller.
Caller with the last 3 digits 505. Please slowly state and spell your name for the record. You have 2 minutes and may begin.
Hello, Peter Guzman, President of the Latin Chamber of Commerce, PETER, GUZMAN. And thank you so much for all the hard work that has been done on this bill. But unfortunately, Our primary concern as a chamber is that this is risky, overreaching, and quite frankly, this is vaguely written legislation that would result in an increased cost of care to Nevadans currently enrolled within employer-provided healthcare plans, which, by the way, is most of Nevada's working population. I also think that it could reduce competition in the marketplace as well as consumer choice. Unfortunately, this is done with well-intentions, but there are unintended consequences, and usually people pay dearly for those unintended consequences. So we ask you to please not pass AB 420. Thank you.
Thank you. Next caller.
Caller with the last 3 digits, 283. Please slowly state and spell your name for the record. You have 2 minutes and may begin.
Marcos Lopez, Marcos Lopez, Americans for Prosperity, Nevada. We rise in strong opposition to SB 420. If the COVID-19 crisis has shown us anything, it's that doubling down on today's bureaucratic approach to healthcare won't work. In fact, we've seen a glimpse of what is possible if we take a different approach, one that trusts doctors, nurses, and medical researchers rather than holding them back. Whether it was the FDA lifting bans and unnecessary rules for COVID test developments, or Governor Sisolak issuing Emergency Directive 011, across the country, we saw the easement of regulations and barriers that stood in the way of innovating and delivering care. The results were clear. Businesses delivered vaccines and therapeutics in record time. We believe SB 420 is doubling down on a bureaucratic approach that we know will make many of the biggest challenges in our healthcare system worse. Centralized approaches to healthcare, like Medicaid expansion, Medicare for all, or a public option, cannot give Americans what they need and what they deserve: affordability, consumer choice, and peace of mind. That is why we advocate and urge lawmakers at all levels of government to advance what we call a personal option. The personal option is a portfolio of policies that expand choice, reduce costs, and guarantees universal access by enacting reforms that focus on increasing the supply of healthcare, reducing costs, increasing consumer choice, and protecting consumers. Americans for Prosperity will continue collaborating with a diverse coalition of healthcare professionals, health scholars, policymakers, and business leaders, and citizens concerned about their healthcare and their country to make changes to improve our system. We urge all lawmakers to oppose SB 420. Thank you.
Thank you. All right, with that, we will go ahead and close opposition to SB 420. I'm now going to open up neutral. I would encourage you, those of you who are on the phone line, please to not take the neutral testimony spot as an opportunity to just do either support or opposition in disguise, but truly only neutral testimony if you could bear with us today. So for those of you who are on the line who'd like to testify in neutral to SB 420 with a 2-minute limit.
Thank you, Chair. If you'd like to testify in a neutral position to Senate Bill 420, please press *9 now to take your place in the queue. Caller with the last 3 digits, 490. Please slowly state and spell your name for the record. You have 2 minutes and may begin.
Good afternoon, everyone. My name is Cyrus Hojjati, Cyrus Hojjati. I'd like to first of all thank the Majority Leader, Canizaro, for bringing a public option. I'm very confident that it's going to reduce costs, bring some competition. It certainly would be great if we could have that for the housing market. I just would like to get more evidence on where similar ideas have been tried. I've heard in Minnesota, but I'd like to get more and more evidence. The other issue is that it's also about immigration status. I'm just concerned that non-citizens could take more than to actually pay back in, so this could create an unequal situation. And speaking of evidence, I want to keep in mind that the ACA has not lowered premiums. It's jacked up premiums a lot. The repeal of the 1973 HMO Act has certainly skyrocketed premiums more than adjusted for inflation, more benefiting Wall Street. We also have to learn from other countries around the world, particularly in Europe, that they pay far less per capita than we do here. I'd like to know how we can learn from those other countries. It is not just health insurance that really concerns me. I'd like to also make sure that hopefully this bill understands that why are people getting so sick? For an example, we have very high alarming obesity rate. We need to understand what is causing these types of illnesses. And speaking of Senator Cannizzaro, the district that she represents is a very car-dependent landscape of urban planning. Maybe that is what's increasing the illness, the stress, the obesity, a lot of other different concerns. So we need to focus on that. And in addition to whether this plan has even worked or not, I'd also like to know, is there a lot of Wall Street healthcare lobbyists that are pushing against this plan? And if there is, then I would perhaps change my stance to support, because we know that these are some. But other than that, I'm just really concerned about waste. I think competition, however, is very, very important. So I'm just kind of concerned, but optimistic. And other than that, thank you guys so much for bringing this up to the table. And we look forward to provide lower healthcare costs for Nevadans. Best of luck to all.
Thank you so much. Next caller, please.
Caller with the last three digits, 398. Please slowly state and spell your name for the record. You have 2 minutes and may begin.
Good afternoon, Chair Reddy and members of the committee. My name is Nancy Bowen, Nancybowen. I am the CEO of the Nevada Primary Care Association. We represent federally qualified health centers serving more than 107,000 Nevadans with integrated primary care, behavioral health, and dental services. NVPCA supports affordable quality health care for all Nevadans, and we believe that a public option could be an important tool to expanding access to underserved communities. We appreciate Senator Cannizzaro's efforts to include F2HCs in this policy, and that SB 420 establishes payment for our health centers on par with what they receive for Medicare or Medicaid. We also support the expansion of Medicaid coverage to pregnant women above the current income eligibility level, and for doulas and community health workers to extend the abilities of our health centers to provide care outside the clinic. We have long advocated for the expansion of managed care so that our rural patients can access specialists in the cities and in rural population centers, and we are grateful to see this policy in the bill. We have concerns about the effect of SB 420 on the future of managed care in the state and on the viability of our hospital and other referral partners. We have heard the concerns from these essential community partners, and we are withholding our support until we understand more about the likely impact of this bill on them. Thank you for your time.
Thank you. Next caller.
We are currently in the neutral position on Senate Bill 420. If you'd like to testify in a neutral position to Senate Bill 420, please press *9 now. Caller with the last three digits, 712. Please slowly state and spell your name for the record. You have 2 minutes and may begin. Caller with the last three digits, 712. You can press *6 to unmute yourself.
Good afternoon. My name is Amber Federizo, spelled AMBERFEDERIZO, speaking on behalf of the Hemostasis and Thrombosis Center in Nevada, currently serving all patients with bleeding and clotting disorders in the entire state, including all tribal land. We wish to testify in neutral at this time. MCOs in Nevada that cover Medicaid recipients are not required to credential providers, even if the provider is willing, or even if they're the only federally recognized center of excellence for the treatment of bleeding disorders and clotting disorders in the state. For example, currently, Smart Choice Medicaid and ERISA plans, such as Culinary, continue to deny access to their members to the state's only federally recognized hemophilia treatment center in Nevada, and their members continue to pay cash to access care. We have provided research to both of these payers that this specialized care, delivered as a HRSA program, reduces mortality and morbidity by 40% at a cost savings. This data is published in a peer-reviewed journal. It has not made a difference. As currently written, this bill does not clearly require MCOs providing care for Medicaid recipients or those who will be offering a public option to contract in good faith with all willing providers who already contract with fee-for-service Medicaid. We have been willing to accept any contract made in good faith. However, we have been denied by such insurances stating they have an adequate network despite having no federally recognized hemophilia treatment center in their network. One provider that is not required to meet federal outcomes is not network adequacy. We look forward to the evolution of the bill to better address network adequacy. Thank you.
Thank you. Next caller.
Chair, you have no more callers in the neutral position at this time.
All right, thank you. We're going to go ahead and close public testimony. I will just pause for a moment here to say that we never like to have to cut off public testimony, but I do believe that we did a decent job today of developing a record on this bill for understanding where folks' positions are. My email has been very active to see the folks who are sending in their written comments, and so I just encourage folks to continue to do so to the email on the agenda. And again, we will post anything that comes in by midnight tonight as an exhibit, so that it will, as long as it doesn't have any of the precluding items in it. So you've got until the end of the day to make sure that we get your comments and we build out that record even further. With that, I'm going to invite the sponsor of the bill back up to make some closing comments.
Thank you, Madam Chair and members of the committee. Nicole Cannizzaro, Senate District 6. I first want to just thank the committee for taking the time today to hear this bill and for going diligently through the testimony, and for everyone who has engaged on this since, gosh, prior to even the 2019 legislative session. You know, one of the things that was brought up is that we really should just look at why there are people who are uninsured. We should look at what we could be doing. And I am just at a little bit of a loss of words with some of those comments for we should study this, we should figure out why people aren't insured, we should figure out why people aren't accessing health care, because that's a question that's been raised for as long as I've been in this building, and while that's not as long as some, it's a long enough period of time for me to know that it's time to take action, and that's what Senate Bill 420 is trying to do. You know, we talked about and looked at, prior to the 2017 session, the Medicare buy-in, and there was issues with that, and that needed to be looked at further. There was some additional analysis done in the last legislative session. There was proposed legislation, and that quite wasn't hitting the mark, and so we should do some more looking at it. We passed SCR 10 and did an actuarial analysis during the interim that came out with some data. We know who the people are who are uninsured. And now the question is, what do we do to try to get them insured? And that is exactly what we are trying to do. This bill, I would also note, in contrast with bills in other states, provides for lead time for DHHS to be able to put together a program that will work, that provides for the time to study it in the interim, and that provides for that procurement period such that this would be something that takes into consideration all of those points that have been made. But the answer to why we should not support SB 420 being that we should continue to look at this or figure out who these people are or figure out how we should study this a little bit more, we are past that point. We know who these people are. I've talked to them at the doors. I would encourage you, go knock 10 doors in your neighborhood and let me know how many people talk to you about the cost of healthcare, because I'm willing to bet it's a fair number. One of the things that has come up a lot is this cost shifts. I again want to emphasize that when we are talking about the individuals who are qualifying for these kinds of plans, most of them are uncompensated care right now. Those cost shifts are happening in the market right now. And yes, there will be cost shifts. We're dealing with healthcare. We know that even under multinational employer plans that are the best plans that you can have, and you're paying premiums, or your employer is helping to pay those premiums and providing that health care, there are still costs associated with that. You can't say that because there are costs associated with it, we should do nothing. We should do nothing to help these folks who don't have care, who aren't accessing it. And so the question is really, when we talk about cost shifts, because that is a current reality of our system, there's plenty of money that is being made in the healthcare space. And so when we talk about cost shifts, what are we talking about? Here, we are talking about people who are not accessing that care because they don't have health insurance. And that's what Senate Bill 420 is getting at. So one of the things that has come up, and it's a little perplexing to me, that the biggest argument is what we really should be doing is expanding people on Medicaid. That's what we should be doing. If we expanded people on Medicaid and expanded eligibility for Medicaid, and providers and insurers were provided those Medicaid rates, that would be a better alternative to putting someone on a health plan where they're paying premiums, and where if Senate Bill 420 passes as is, that floor is a Medicare reimbursement, and that's a floor, which I think it will be my next point briefly, Madam Chair. Adding people to Medicaid and saying, well, I would take more Medicaid patients and get reimbursed at a Medicaid rate, and that's what we should do instead of implementing health insurance, and yet in the same breath making the comment and the argument about cost shifting is perplexing to me, because Medicaid rates are low. And if we're talking about implementing something where you're getting reimbursed at higher than Medicaid rates, why that's a reason to oppose this bill is just one that I have struggled to understand in every sense of the word. With respect to the Medicare rates, and the comment was made that the government is setting the rates and that this is only Medicare compensation. That's not what Senate Bill 420 is. One of the concerns that we had in discussing this through the interim and discussing it with a number of stakeholders was a concern that they would end up with Medicaid rates. And so we tried to put a floor into the bill to provide that as some reassurance that they wouldn't be getting the Medicaid rates. What this should do, and what this is intending to do, and with the ability of the state's purchasing power and the ability to apply for waivers and subsidies to help buy down those costs, is that the health insurers should be negotiating with providers for those rates, knowing that that's the floor, but should be negotiating. And these are folks who negotiate for a living. I understand that. This is something that is going to incentivize them to provide those value-based plans that are actually showing real health outcomes. And so again, this isn't the government setting rates. It's not a state. There was another piece of opposition that this is a state-run program that is being subsidized by the taxpayers. This is allowing the state to get creative and to get innovative, because again, we can't study this anymore. That time has come and gone, and we have the studies and we have the data. Even so, and the other point I'll make, Madam Chair, before kind of wrapping up here, is that in this bill, there is the provisions that would allow for actuarial analysis. A 1332 waiver is going to require that, so that is also part of the bill. If we were going to do that 1332 waiver, there would have to be some actuarial analysis to go along with that in order to support that. And if that's what gives people more assurance, I'm happy to negotiate on the terms of the bills to ensure that that does happen, because that is our intent. We've talked about the percentages of the premiums. One thing I wanted to point out was that in Colorado, in their legislation, in the more negotiated, moderate compromise version with the healthcare industry for their bill, was 18% reduction in premiums starting in 2022. We're giving lead time. We're at 15% over 4 years after the plan is enacted. So I think that's worth consideration. And with respect to the concerns about the provider participation pieces, those provider participation requirements have worked in Minnesota. So we have data that does work. And I think that this is absolutely not only the right thing to do, but also something that is going to provide that additional piece. The idea that there are just enough choices and we don't need any more choices, then Nevada wouldn't be 7th in the nation for uninsured at a persistently high rate, where we are actually the only state in that 7 that has that did elect to do Medicaid expansion. That has got to tell you a lot about whether or not there's an issue here, whether or not there are sufficient choices, and what we should be doing about it. Again, this does not affect employer-based health plans. It doesn't affect association health plans. So those are not what we're talking about here. But what we are talking about is, how do you provide affordable and accessible health care to Nevadans when we know that there is an issue? And I think that this is a step in the right direction. There are some folks that we are still working on with amendments. We will continue that work. And I will stop there, but thank you, Madam Chair, very much for the very generous amount of time that you have allowed for us to present what I believe to be a very important issue.
Thank you, Majority Leader. All right, with that, I'm going to close the hearing on Senate Bill 420. Thank the Majority Leader for bringing the bill. By way of logistics, team, we're going to take a 5-minute break, which will also allow those of you who only had an interest in 420 to exit, because I know there's some folks who would like to come in for the next bills that we are hearing. So folks, let's be back at 6:10. It's a 7-minute recess. All right, I'm going to bring us back into session. We are going to move on and open up the hearing on AB 205 and invite Assemblywoman Cohen to present the bill.
Leslie Cohen, Assembly District 29. Thank you, Chair and Committee, for hearing AB 205. Presenting with me is Trey Delap from Group 6 Partners. Mr. Delap has worked in behavioral health, addiction, and recovery policy for years and specializes in advocating in the spaces where they converge. So he's going to give us some information about opioid use very briefly and quickly.
Good evening, Madam Chair. My name is Trey Delap. For the record, David Ed Easy Lincoln Adam Paul. Thank you, Assemblywoman Cohen, for Assembly Bill 205. This deals with naloxone in schools, and what I want to do is give some background data information for the committee's consideration. So the reason this is very relevant at the moment is we've seen a substantial increase in overdose deaths in 2020 specifically, for especially for young people under 17. All deaths recorded here or in 2020 were unintentional opioid overdose deaths attributable to fentanyl, the synthetic opioid. Overall, the state saw a 29% increase in the death by overdose of opioids in the adult population, and the synthetic opioids account for 2 times the overdose deaths of heroin. Teen deaths were on the rise, and they were coming down, and now they're going up again. The death rate, the number of young people who die by overdose of synthetic opioids equals double the peak year of the opioid epidemic, considered to be 2011. The sum of, in 2020 alone, the opioid overdose death in the 8 to 17 population was a third of the total number of the same population in the last decade. It's a significant spike. Prevalence of opioids among young people is relatively high, and young people are having access and using illicit drugs. 34.7% of young people in grades 8, 10, 12 have used illicit drugs during their lifetime. 27% of those have used them in the preceding year. An example is if they reported that they've used illicit drugs in 8th grade, that means sometime between 7th and 8th grade they've used illicit drugs. This gives us pause to sort of take a look back at what the opioid epidemic has been and how this has been evolved. And I want to take a moment to note the year 1995. 1995 was the year OxyContin hit the market. 1995 was the year that the 5th vital sign was designated as the 1 to 10 of pain. In 1995, I was a junior in high school working at Boulder City Hospital, and this was a change that was going on there. So also in 1995, the Nevada Board of Pharmacy activated one of the first in the country prescription monitoring programs. This was the brainchild of Keith McDonald, and it was considered to be very innovative at the time. So between 1995 and 2015, an opioid epidemic erupts, and then the first piece of legislation that the Nevada Legislature enacts is the Good Samaritan Bill in 2015. The first thing the Nevada Legislature did in response to the opioid epidemic was to create a harm reduction safe harbor encouragement for people to intercede when opioid overdose is occurring. This was a key piece of legislation. In 2017, a comprehensive overhaul of prescribing occurred, and the PMP became mandatory. And one part of this too is that these are Nevada things, but when we look at opioids globally, the United States is the largest consumer of morphine, accounting for almost 40% of the world's consumption of morphine. This is an indication that we have a future that's going to include opioids, and that is part of the connection that we're looking at for schools. Fentanyl, the United States consumes 20% of the world's fentanyl. Now, the public sentiment regarding the opioid is that 51% of the public believe that opioid epidemic is a serious problem, and 67% of the public believe that there's lack of access or funding for treatment or mitigating services with regard to the opioid epidemic. 56% of people believe that the opioid epidemic negatively impacted local economies and job growth. The number of overdose deaths from heroin between 1999 and 2019 dropped. Approximately 20% fewer deaths from heroin, but those deaths were picked up by fentanyl overdoses, which was, again, 29%. With regard to the specific impact on children, 2.2 million children have a direct impact with someone in their family that has opioid use disorder. They have lost a parent. Of these, 170,000 young people have overdosed on opioids that were in the house. This was reported by the ripple effect. So this also intercedes with childhood trauma and the ACEs study that it's been ongoing for a while. Of the 2.2 million kids that are directly affected by the opioid epidemic, 2/3 or 41% are 5 or younger. Another third are between the ages of 6 and 11, and 27% are between the ages of 12 and 17. Now, things have changed. I mentioned earlier that in 2017, the PMP, the Prescription Drug Monitoring Program, became mandatory, and this was designed to target the first phase of the opioid epidemic, which was overprescribing. So the PMP becomes mandatory, and have we seen a drop in opioid prescriptions? We have seen a drop in opioid prescriptions. Also, the average daily morphine equivalency, the MME, morphine milligram equivalent per opioid prescription, has decreased as well. So the raw number of prescriptions have gone down, and also the quantity and amount or potency has dropped. Now, also, innovations with regard to the House of Medicine and its response to the opioid epidemic is the co-prescribing of naloxone and Narcan. The VA has been doing this for a while. If they write prescriptions for opioids, they also write prescriptions for Narcan or naloxone, and will educate others in the household on its use. The top 3 physicians or the top 3 prescribers by category writing for naloxone is psychiatry is number 1. Second, intuitively, addiction medicine, but third is pediatricians. Pediatricians account for the third largest group of prescribers who are writing for naloxone. The American Academy of Pediatrics has identified that as part of a mitigation of harm and awareness of the impact of the opioid epidemic on children, they have been engaging and doing analysis and monitoring the impact of children going into the foster care system and all of that. And they published a number of things talking about families affected by parental substance abuse. This again connects to the availability of opioids. So opioids may be available in the house for whatever reason, and then kids are able to get access to them. And then there's also the strong market and demand. The profitability of synthetic fentanyl is tremendous. If a drug dealer has 1 kilogram of the source material, they have 2 choices. They can make a kilogram of heroin, or they can make 20 kilograms of fentanyl. The kilogram of heroin will yield $80,000 in revenue. The 20 kilograms of synthetic fentanyl opioids will yield $1.6 million in revenue. So there's demand in the prevalence, demand in the use and awareness, and there's certainly a profit motive. Southern Nevada has seen this spike and is doing what they can with public education. Following the last session, NICRIP, the Nevada Institute for Child Research and Policy, prepared a policy brief specifically addressing the availability of naloxone in public schools. And all of this information suggests that we should do something. The opioid epidemic has been an all hands on deck response, and there have been things that are are working, and we're still doing things and tweaking things, and so this is an important piece of legislation, and I'll yield there to Assemblywoman Cohen and the committee. Thank you, Madam Chair.
You bet. Assemblywoman Cohen?
Thank you. Again, Leslie Cohen, Assembly District 29. And the Nevada Health, the Health Department has reported the age range of use of opioids in Nevada is falling to such an extent that the average age has fallen from 49 years old to 29 years old. The federal government, in an effort to stop the health crisis, has been giving out opioid antagonists to prevent overdose, and that's without qualification. In fact, the Nevada Osteopathic Medical Association, National Association of School Nurses, and Substance Abuse Mental Health Service Administration of the U.S. Department of Health and Human Services have confirmed that Narcan is safe and can be given without harm. According to the Nevada Osteopathic Medical Association, quote, naloxone or Narcan is a safe and effective drug for the treatment of suspected opioid overdoses in the event that the drug is administered to a person who is not experiencing a narcotic overdose, but other medical event, it will not cause harm. So to be clear, if someone's overdosing from an opioid, they're going to die without intervention, right? Often lives are lost waiting for the ambulance to arrive, and naloxone administered while waiting for the ambulance saves lives. It's safe, it's more benign than epinephrine, and it's administered to someone who is not overdosing, or when administered to someone who's not overdosing, it doesn't harm them because it's a blocker. So at different times, I and other legislators have distributed to different people in the building naloxone kits, like this. With money from the federal government, the Nevada State Opioid Response reports they have distributed 13,185 kits and 932 reversals from the use of naloxone. That's 932 Nevadans who would have died if they didn't receive naloxone. However, organizations such, and then this kit I have is from Partnership Carson City. There's gloves, some information on opioids, instructions, and a couple of naloxone sprays, but you really don't have to have training. You can just read the pamphlet and you can save someone's life. Organizations such as Partnership Carson City provide free monthly training. Training takes about 30 minutes to an hour, and in the training, administration of the naloxone itself takes about 10 minutes. The training also stresses calling for medical help. So what we have is that there's a problem, there's a way to solve it, and that way to solve it will do no harm. And our children are beginning to overdose on opioids more and more. It's, 8 unintentional overdoses in Nevada is the number that we have right now, and that's a 300% rise in numbers. Also, I understand there were also 3 overdoses in one of the Reno high schools. So it's just something that we need to deal with and take care of. And if it's okay, if you'd like, I can go through the bill very briefly.
Generally, the Senate HHS committee is not interested in bill walkthroughs because we're
Okay.
very good bill readers. We're
Good.
very good bill readers here in Senate HHS.
If,
All right,
if
I
I could
think we are
just
good.
stress one thing before we start questions.
Absolutely.
This is enabling language.
No mandate.
I'm sorry?
There's no mandate.
No mandate, enabling language.
Great, thank you. All right, thank you for the presentation. Assemblywoman Cohen, members of the committee, questions? I can see it's built on the very beautiful work of Senator Debbie Smith with the EpiPen legislation, and so high level of confidence that it can work and save lives if that's the framework that it's built on. I don't have any questions either, so we're going to go ahead and open up public testimony. Is there anybody on the phone line who would like to testify in support of AB 205? Again, we'll do a 2-minute limit.
Thank you, Chair. To testify in support of Assembly Bill 205, please press star 9 now to take your place in the queue. Again, if you'd like to testify in support on Assembly Bill 205, please press star 9 now to take your place in the queue. Chair, you have no callers at this time.
All right, let's go ahead to opposition on AB 205.
If you would like to testify in opposition, to Assembly Bill 205, please press star 9 now to take your place in the queue. Chair, there are no callers in opposition at this time.
We'll go to neutral. Is there anybody who'd like to testify in neutral on AB 205? Almost claimed your bill.
If you would like to testify in the neutral position to Assembly Bill 205, please press star 9 now to take your place in the queue. Chair, you have no callers indicating neutral support at this time.
All right, we'll close the public testimony and bring it back to the sponsor. Any final comments?
Leslie Cohen, Assembly District 29. I would also like to say that this is also built on the work of Speaker Hambrick in the last session. The bill just wasn't quite there at the end of session. With that, thank you.
And if you could just pause for a minute. Senator Spearman, I just noticed your camera was on. Did you have a question or a comment?
Yes, I was just going to say, as she was reading the bill, I thought about Senator Smith, and especially know that the work she started, we're still continuing. So, thank you.
Great, thank you, Senator Spearman. All right, we'll go ahead and close the hearing on AB 205 and open up the hearing on AB 96. And thank you, Mr. Jalap, for your time today.
Thank you, Leslie Cohen, Assembly District 29, and thank you for hearing Assembly Bill 96. It's a very brief bill. It's not an earth-shattering bill, but I think it kind of sets the stage for us to continue to do some work that's been going on in the state. The bill came from my interest in peer support for first responders. I heard a radio news story about a program for peer support for first responders in another state that was just having great results, and one of the people interviewed spoke about how most of us run away from bullets, run away from fire. So when the people who run toward fire and bullets, when they're in crisis, it's easier for them to open up to people who know what that's like, which is peer support. And they do need to open up to get support. According to the supplemental research bulletin from the Substance Abuse and Mental Health Services Administration of the United States Department of Health and Human Services, which was based on literature and scientific publications found through the National Center for Biotechnology Information and U.S. National Library of Medicine. It's estimated that 30% of first responders develop behavioral health conditions, including but not limited to depression and post-traumatic stress disorder, which compares to 20% of the general population. The bulletin referred to a study about suicidality, noting that firefighters were reported to have higher attempts and ideation rates than the general population. And according to a different study, a national study, more than twice as many firefighters die from suicide than in the line of duty. According to a study by the Ruderman Foundation, both policemen and firefighters are more likely to die by suicide than in the line of duty, which is just shocking. Moreover, the white paper noted that Firefighter Behavioral Health Alliance estimates that firefighter suicides are substantially underreported on top of all of that. First responders are at risk for PTSD, depression, substance abuse, and suicide ideation and attempts. Both natural and technological disasters were found to be associated with increased risks of these conditions. And a technological disaster is a catastrophic event that is caused by either human error in controlling technology or a malfunction of a technology system. And there's as serious as natural disasters, like bridge collapse, that type of thing. Emergency medical service personnel are not immune to mental health issues either. According to the bulletin, one of the core risk factors for first responders is the pace of the work. One study noted in the bulletin found that 69% of EMS professionals have never had enough time to recover between traumatic events. The result is depression, stress, PTSD, suicidal ideation, and other functional and relational conditions being reported. So the good news is, since I started thinking, gee, we should do something, first responders, their supporters, and mental health professionals have started to do something, which is part of why I substantially amended AB 96 in the Assembly, so we can help first responders while, frankly, not spending funds we don't have. And the legislation won't counteract any of the good work that's been done by first responder peer support groups, and I hope in the future we will have the funds to be able to do more. I won't do the walkthrough because you're good readers, and but I will let you know that with us is Margot Chappell, the Deputy Administrator of Regulatory and Planning Services of the Division of Public and Behavioral Health. She's available to answer any questions. She and her office were extremely helpful, kind of narrowing down the bill so we could get rid of the big fiscal. And again, it's not a big bill, but it does kind of do some important things like data collection and getting that information about peer support first responders out there, and kind of sets the scene for us being able to come back later and maybe provide some financial assistance in the future when we're able to, as first responder, peer support for first responder grows throughout the state. So I'll leave it at that.
All right, thank you. Questions or comments from the committee? I will just ask, we're seeing a lot of bills this session which have the language of within the limits of available money or as money is available. And so I guess my question may be more for Ms. Chappell. I mean, is there anything that we are currently doing out of the Office of Suicide Prevention or out of any of the behavioral health initiatives through the block grants or anything along those lines that does align with this? Or what other efforts the committee should know about in terms of making sure that our emergency responders have the behavioral health support they need?
Thank you, Margot Chappell. For the record, there may be, and frankly, I'm sorry, we don't have Dr. Woodard on the line to answer the question about SAMHSA and some of those others, but we are looking at the fees for licensed our EMS folks, and the advisory committee will be given an opportunity to increase those fees. That's one of the opportunities we're looking at for being able to contribute to this and fund that. However, and I really don't know how the gentlemen who are offering the program currently, and I say that because they are men, but there could be women who do the same job, but just right now it's men who are doing it, and I don't know how they're funding it right now, and they may have some ideas as well. So I apologize, I can't be more definitive.
No, that's okay. So there is a peer support line that's operating for EMS providers today?
That is correct. There, as I understand it, actually, I think the Assemblywoman probably has more information about that than I do. I understand there's one in the north and one in the south.
Okay. So the idea being then that the framework is built, there's already somebody doing it, but if money could be found, we could expand on those efforts.
Leslie Cohen,
yes, Mark Chappell, for the record, yes.
I'm sorry, to the Assemblywoman, I should have been more clear.
Sorry, Leslie Cohen, Assembly District 29. Yes, there, like I was saying, as I was kind of like, gee, we should do something, they actually did start doing something. And so there is a program. I know they're in the north. I believe they're still working on getting to the south, but I could be wrong about that. And they could be there already. And so this is just kind of getting their information out there. And then also there is a data collection piece to this as well, so that we can start to get the data about suicide attempts and suicide in first responders.
I will just note that the data collection is also to the extent money is available. So
Yes.
I will acknowledge that I'm getting a little skeptical about to the extent money is available bills this session, but I hope that we actually find a path to do some meaningful work here.
Leslie Cohen, Assembly District 29. I agree exactly. And there's also the pieces about getting the information out, having the place for information to flow through that type of thing. So it's not just coming from a not-for-profit, but that the state is providing that information to people who might be looking for it.
Great, thank you. Any other questions or comments? Seeing none, we'll go ahead and open up public testimony on Assembly Bill 96. Those who'd like to testify in support, BPS, please help us out.
Thank you,
Two-minute limit.
If you would like to testify in support of Assembly Bill 96, please press *9 now to take your place in the queue. Again, if you would like to testify in support of Assembly Bill 96, please press star 9 now to take your place in the queue. Caller with the last 3 digits, 300. Please slowly state and spell your name for the record. You have 2 minutes and may begin.
Good afternoon, committee and Chair Ratty. This is Tony Yarbrough for the record. That's spelled Tony, T-O-N-Y, Yarbrough, Y-A-R-B-R-O-U-G-H. I am representing about 9,000 members of the Veterans of Foreign Wars of the Department of Nevada. And I also represent roughly 500,000 members of the United Veterans Legislative Council as a past officer. UVLC is an organization of all the veterans organizations throughout the state of Nevada. That includes all veterans, active duty military, National Guard, family, and advocates statewide. And the reason why I am testifying is because a lot of the folks that are first responders, that are law enforcement, et cetera, and firefighters actually come from the roles and the ranks of our military and our veterans. And for that reason, we recognize that one of the biggest challenges that we face today is the fact that we have a very high rate of suicide among our members. And that's also true in the same situation. There's a different world for the average civilian who has to deal with a trauma on a daily basis, and death and carnage and difficulty of actively performing their jobs. So we recognize that this really could actually impact veterans, and we want to support that. Suicide prevention is our #1 goal, and we recognize that peer support is a proven foundation of success. It helps to identify the causation as well as the prevention. And for that reason, we believe that this is a good start, because we know, as we already know, we haven't been able to stop suicides. All we can do is try to prevent it. So we go through a combination of training, we go through a combination of exercise, counseling, and peer advocacy. And with that, I will say, please, please support this bill. I really thank you for your time.
Thank you, Mr. Yarborough, and thanks again for making the time to join us. Others, next
Chair,
caller in support?
Pardon, Chair, you have no other callers in support at this time.
All right, let's go to opposition of AB 96.
Certainly, Chair. If you would like to testify in opposition to Assembly Bill 96, please press star 9 now to take your place in the queue. Again, if you'd like to testify in opposition to AB 96, please press star 9. Chair, you have no callers indicating opposition at this time.
All right, let's go ahead to go to neutral on AB 96.
If you would like to testify in the neutral position on Assembly Bill 96, please press star 9 now to take your place in the queue. If you'd like to testify in neutral, please press star 9 now. Chair, you have no callers in the neutral position at this time.
All right, I just wanted to check in with Senator Spearman. Senator Spearman, did I miss you on questions or comments on this one?
That's okay. It's easy to miss my hand. So I just want to say thank you, Madam Chair. One of the things, and I sent to Ms. Kamlasi a link. One of the things that the VA has done in order to help carry the load is they have trained and fielded peer-to-peer specialists and supports people. So to the extent that money is available, but I think there might be some collaboration we might be able to do with the Department of Veterans Affairs. At least, if not at the federal level, we should probably be able to do something with our Department of Veterans Services here in Nevada. So.
Thank you, Senator Spearman. Closing comments, Assemblywoman?
Just thank you.
All right, thank you. We'll go ahead and close the hearing on AB 96 and open up the hearing on AB 217. Assemblywoman Cohen, please go ahead.
Thank you, Madam Chair. For the record, I'm Leslie Cohen, Assembly District 29. I'm here to present Assembly Bill 217, which came out of the 2019-2020 Interim Legislative Committee on Healthcare. So your own Ms. Kamlasi had a lot to do with helping making soup with it. So it's the result of a study which was AB 131 of the 2019 legislative session, and it requires the committee to examine issues related to training for non-medical caregivers who provide care at certain facilities, compare training standards, and determine whether certain unlicensed employees, and let me be clear, so it's unlicensed employees and contractors, should be required to complete a minimum amount of training. The study specifically addressed the training for the unlicensed staff who provided care for clients and patients in non-medical facilities such as assisted living and community-based living arrangements, as well as unlicensed individuals who work in medical facilities. And these individuals provide a range of services, so it's from helping with medication administration to assisting with activities of daily living, like helping with bathing, lifting someone, helping them eat, helping them get dressed, helping them get on a bus. And again, the key is unlicensed, so not certified nursing assistants, not dietitians, not registered physical therapy. So AB 131 built off a 2017-2018 study by the Legislative Committee on Seniors, Vets, and Adults with Special Needs, which considered many of the same issues, but it found some of the biggest issues couldn't be resolved with training, or it found that some of the biggest issues that could be resolved with training was also related to sterilization procedures, sanitation, infection control, and appropriate care and treatment. And that obviously became a big issue during COVID. According to the Department of Health and Human Services, the top 3 causes of COVID-19 outbreaks in skilled nursing facilities in Nevada were inappropriate use of personal protective equipment, breaches and isolation of infections of COVID-19, and hand hygiene and hand washing. So both the 2017-2018 study and the COVID-19 pandemic emphasized the need for additional and reinforced training on standard infection prevention and control and the proper use of personal protective equipment. And the committee's final recommendation was developed with input from officials within the Division of Public and Behavioral Health, which is responsible for regulating the facilities. So what the committee ultimately decided is the best way to ensure unlicensed caregivers receive appropriate training is to have the State Board of Health adopt regulations prescribing these requirements. And this will allow training requirements to be more flexible and nimble than if they were established in legislation. It will also allow the State Board of Health to revise requirements as new issues emerge. I can skip the walkthrough. I'll let you know, well, and also, I'm sorry, I was remiss. I didn't mention that Mr. Robbins also had a hand in the interim committee and making sure we got the bills ready to present to you. So with us is Margot Chappell, again, Deputy Administrator of Regulatory and Planning Services of the Division of Public and Behavioral Health. I believe she has actual testimony and is not just here for questions. So I will pass it off to Deputy Administrator Chappell.
Ms. Chappell?
Thank you for the record, Margot Chappell. During the pandemic, we witnessed quite a few citations during the in facilities where they had unlicensed caregivers working, and we would just, to give you a couple of examples, we would see people working in the kitchen who would think, since nobody was around, they could take their mask off, so they're preparing food without a mask on. Or some other violations that were really in that untrained, unlicensed caregiver role. So just wanted to make sure that that got added to the record. Thank you.
Thank you. Any additional presentation of the bill? Questions from the committee? Of course, many of us were on the interim committee that have asked for the bill to move forward, so we're a little bit preaching to the choir here on this one. Okay. No questions then? All right, we'll go ahead and go to public testimony. Anybody who'd like to testify in support of AB 217, please go ahead.
Thank you, Chair. If you would like to testify in support of Assembly Bill 217, please press *9 now to take your place in the queue. Caller with the last three digits, 528. Please slowly state and spell your name for the record. You have 2 minutes and may begin.
Good evening, Madam Chair, members of the committee. For the record, my name is still Barry Gold, and I am still the Government Relations Director for AARP Nevada. I'm very pleased to have worked with Assemblywoman Cohn on this concept for this bill all the way since the 2017 session. As I said before, and I'll say it again now, sometimes the state of Nevada is very good for these unlicensed personnel. We fingerprint them, we background check them, and we TB test them, but that sometimes is all we really require. So I think it's really important that when someone brings a family member or they themselves go through the doors of a facility that has these unlicensed staff there that often have caretaking responsibilities, that these people know what they're doing about something. So we don't not know what they're doing. But in terms of what she was talking about, the data, a lot of these facilities, whether they're HERCs, for those of you who don't know what a HERC is, it's a home for individual residential care, or some of these adult care homes, the overnight staff, the people that just stay overnight, the people that do different things, the people that might work in the kitchen, the people that do different things, that do have some caregiving responsibilities. As I said, we fingerprint them, we background check them and TB test them, but we're not sure just how they're trained and what they're tested on. The licensed staff, whether they work in hospitals or nursing homes or adult daycares, they have established training regimens, and that's great. So we know exactly what they're being done. This bill, after a lot of work, is actually the best way to make this happen by regulation, deciding which facilities, which staff, and which training. And by not putting it in statute, it becomes flexible to develop whatever the current needs are. So I think that is just a great idea, and I'm really pleased where this has gone. So I commend Assemblywoman Cohn for sticking with this concept. I remember talking with her about it and thinking this has to be done because we have to protect the people, the most vulnerable people who live or go to get treatment or do something in these facilities. So AARP, yes, on behalf of those 345,000 members across the state, strongly support this bill and urge this committee to pass it. Thank you very much.
Thank you. Next caller.
Chair, you have no more callers at this time.
All right, let's go to testimony in opposition of AB 217.
If you would like to testify in opposition to AB 217, please press star 9 now to take your place in the queue. Chair, you have no callers in opposition at this time.
Thank you. Let's go ahead and go to testimony in neutral.
If you would like to testify in the neutral position to Assembly Bill 217, please press star 9 now to take your place in the queue. Chair, you have no callers indicating neutral position at this time.
All right, we'll go ahead and close public testimony, bring it back to the committee. Senator Hardy.
Thank you, Madam Chair. I would hope that when this passes, maybe even before it passes, that these places will take to heart what our intention is and not wait till January 1st, 2022 to have regulations to force them to do it. Thank you.
Thank you, Senator Hardy. Senator Spearman, anything to add, questions or comments? No, you're good? All right. Looks like we're all good. That will go, I'm sorry, closing comments, Assemblywoman?
Thank you. It's just a modicum of some regulations or modicum of training for people who are dealing with our most vulnerable population, whether it is infectious disease control or, helping get someone onto a bus without hurting them. So thank you.
Thank you, Assemblywoman. I'm afraid we learned a lot of lessons the hard way over the last many months of this pandemic, and I appreciate the effort. All right, we're going to go ahead and close the bill on the hearing on AB 217. Our last item of business before we go to public comment, we'll just say that we will be meeting on Thursday. We have 3 bills on the schedule: AB 287, AB 326, and AB 374. At this time in the session, may add some. We'll just see how it goes. With that, we'll take public comment. Open it up for public comment.
Thank you, Chair. If you would like to provide public comment, please press star 9 now to take your place. Chair, you have no callers indicating public comment at this time.
Thank you. Again, I will just express my gratitude to the team at BPS who keeps us going with all of this wonderful technology we're using this session, our Legislative Council Bureau staff, Ms. Kamlasi, Mr. Robbins, and everybody who you don't see behind the scenes that helps them out, as well as our Senate staff, Nicole Flangas, Vicky Polzing, and Norma Mallet, who have done an outstanding job this session. And folks just don't get to see. So thank you to everybody, as well as just all of the staff who are keeping this building functioning in the midst of a very strange time. With that, we are adjourned.